Thank you. Um, Good afternoon and welcome to the second Health and Adult Social Care Overview and Scrutiny Committee for this municipal year. Before we start these proceedings, may I bring to your attention some housekeeping matters. There is no expected fire alarm testing today. Therefore, if the fire alarm does sound, please follow the fire and emergency procedures that are applicable to the Council House. This meeting will be broadcast live to the internet and will be capable of subsequent repeating viewing by entering the Warspite room. Committee members are consenting to being filmed throughout the meeting and to the use of those recordings for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it's switched off when you're not using it. And your mobile devices are turned to silent, please. I have checked mine is on silent. So we're going to go to item 1. Apologies, Elliot.
Thank you, Chair. Through you. Apologies from Councillor Riley. Councillor Stevens is substituting today. Apologies from Councillor Penrose. Councillor Gilmore is substituting today. And apologies from Councillor Mahoney, who's running late. Thank you, Chair.
So none from Natalie or Leafin?
No, Chair.
Okay, thank you. Item 2, minutes of the last meeting. Can I ask everybody to approve the minutes of the meeting held on the 27th of June as a correct record? Thank you. Thank you, Councillor Nicholson. Thank you. Item 3, declarations of interest. We've got any declarations of interest? Will?
I work for University Hospitals Plymouth NHS Trust.
There is no chair's urgent business, so we can skip that. Item 5, quarterly performance and financial update for health and social care. And that's going to be presented by Rob and Helen. Thank you.
Chair, can I just come in first and say thank you very much, folks, for inviting us along again today. This report, which we produce for scrutiny each quarter, provides a comprehensive overview of some of the key performance and activity metrics that are used by the Council and its partners, including the ICB and Live Well South West. The report draws on the information from all the aforementioned organisations, as well as the University Hospitals Plymouth. The information within it is used operationally and strategically by officers and senior managers across all organisations to ensure that the best possible outcomes for people, including the health and social, within the health and social care system. So I'm going to hand over to Rob Sowden now, who is the performance advisor for the Council, and he will provide you with some of the key headlines from this report. Thank you, Rob.
Thank you, Councillor. There's a lot of information contained in this report, which starts on page 26 of your pack, and it presents only a fraction of the data and information that we have access to via our system dashboards that we use operationally. If you do have any questions regarding this data that you want to ask outside of this committee, then please do not hesitate to contact me directly. I won't go through the report line by line so as to leave plenty of time for questions, but I will just give a headline from each section. Due to this meeting being pushed on a month, some of the numbers in this report might look a little bit out of date. So where I can, I'll just verbally update you on what the very latest figures are. So page 28 of the report gives an overview of Live Well South West referral service, or commonly known as the front door to our community adult social care. And whilst demand remains relatively steady, our colleagues at Live Well have done a lot of work to reduce the waiting lists. This is evidenced with both waiting lists for adult social care support and on adult social care occupational therapy, both on a downward trend. As of this week, so that's week commencing 23rd of October, the waiting list has dropped further than what is in your report and is actually down to 114, which is good news. The occupational therapy waiting list currently this week sits at 64, so that's slightly up from the numbers that are in your report. Page 29 looks at the outcomes of referrals into adult social care, as it's important that we have a system that has a strong community-based alternative to long-term care in place. We know that data that those 90% of those subject to a referral into adult social care will not go on to receive a long-term care package. Our Caring for Plymouth model aims to support that by providing the early support and reducing the need for long-term care. I would like to apologise to the committee that the data on this particular page hasn't been updated. That's to do with we've changed systems around adult social care, and that's impacted on us being able to report via the dashboards. It's a temporary issue that will be rectified going forward, and we'll be able to update you at the next meeting. On page 30, that illustrates our much improved position in relation to the number of people waiting for a domiciliary care package. To give you an idea of how improved we are, the waiting list number today, yesterday, 25th of October, is 20, and that's 85% down from where we were at the 1st of January 2023. Not only is it much lower, but during October, the daily waiting list average was at 21. So whilst the teams have worked really hard to bring that waiting list down, they're also managing to maintain that. So again, it's really positive news with regard to the waiting list. Our numbers in dom care have also plateaued, and they've been going up for over the longer term on an increasing trend, which has been a pressure, but just these last few months they've started to plateau. Page 31 tracks our numbers of people going into our Independence at Home service, which is, I'm sure you will all be aware, is our reablement service. And we know that on average in 2022-23, 66% of people left that service with no ongoing care needs, which of course is the best possible outcome for those going into that service. That between April and August this year, that average is up to 73. So we are showing an improvement in the percentage of people leaving reablement with no ongoing needs. Page 32. We are facing a challenge and have been for some time with regard to our long-term placements into residential and nursing care. They have been going up. Just to give you an example of that, for admissions of older people, that's people aged 65 and over, going into nursing care homes, they increased by 57% in 2022-23. Higher admission numbers have continued in April and May of this year, but between June and August, we've started to see that slow down a little bit. So that's good news in terms of admissions. However, the numbers of people who are in receipt of care within residential and in particular nursing care homes, those numbers remain quite high and are a pressure for the service that they're working to improve. Page 33, very similar story to domiciliary care mentioned earlier. Number of people receiving a supported living care package is increasing. The waiting list, which tends to fluctuate a bit more than domiciliary care, is also for a period of about 6 months been reducing and continues to be low. On page 34, that tracks our numbers of people in receipt of a direct payment. And you can see that in the report is over the longer term on an increasing trend. people receiving a direct payment is a positive for them because it means that they are spending money on on care in the way in which they want to do that. So for us to be pushing that up is something that we want to achieve. We know that we benchmark below regional and national averages, so it is an indicator that we're looking to improve on. You'll see the very right-hand side of that chart that it's just started to go down just a little bit. So that is a concern because we wouldn't be expecting that to be happening. So that will be investigated as an action from the departmental performance team. Page 35 tracks our safeguarding outcomes. These are alleged incidents of abuse on adults, but not all those adults subject to abuse will be in receipt of a social care package. The Plymouth Safeguarding Adults Board gets this performance information as well and scrutinise it accordingly. This report gives us a review on how well we are achieving making safeguarding personal outcomes for those who have been subject to abuse. I'll just repeat, because I know I would have mentioned it last time, but just what that is at the beginning of investigation, the victim or their representative will be asked in conjunction, in conversation with social workers to what they want to achieve, what is the best outcome likely to be for them at the end of the investigation. We know that last year, 97% of cases fully achieved or partially achieved what those agreed outcomes were, which is really positive. In Q1 of this year, that rose to 98%, and that's been maintained in Q2. So it's really positive outcomes for those who are subject to safeguarding abuse. What we do know though is demand remains high in that particular area. Page 36 looks at complaints and just gives a summary. They can come through 3 routes: via Live Well Southwest, via the council, or there'll be LGO complaints. Overall, numbers remain quite steady, and the numbers in the report go up to July. That I can confirm that there were 6 in August. So actually, the static trend has continued into August. And finally, page 37 just gives a bit of a visual on the healthier picture in regard to the number of people delayed at University Hospitals Plymouth. Performance is on an improving trend over a longer term. During 2022, the daily average was 77, and between January and August this year, that average has dropped to 32. Chair, I'm aware there's a lot of information to take in, and I've gone on a bit, but I'm happy to try and take any questions that the committee might have.
Thanks, Rob. Mary, do you want to say anything before I go to questions, or are you quite happy?
Chair, I just wonder whether it's worthwhile bringing that item 6 into this as well, which is that no right to reside update, since it's the last bit of information on that page. Whether you want an update on that now to help any questioning.
I'm quite happy to wait, actually. Thank you. Before I go to Patrick, Rob, you were saying about how these figures have dropped or whatever. That's absolutely brilliant. So we're saying that waiting lists have dropped, but it doesn't say anywhere in here how long that waiting list is. So for me, I mean, you're saying that we've got 32 people or on a waiting list, but how long is that waiting list? So how long are these people waiting? That's all well and good, but I would like to know how long they're waiting.
So I can certainly add that into the report going forward. I don't know whether colleagues know what the current waiting time is. So I don't want to give you a false figure now, but I can certainly get that to you after the meeting, and I can add it in as a new metric going forward. Absolutely, and I'll do that for all the service areas. Yeah, no problem.
Thanks, Pauline, and thank you, Mary and Rob, for the report. And I agree with the point you make, Chair. Just in relation to domiciliary care, obviously it's been a difficult market for a long time, so well done for bringing the number of people waiting down. But could you give a bit of narrative in terms of the market and employee sort of recruitment and retention? Because certainly that was an area where there was an impact on our ability to deliver. So that's one question. And the other is around so nursing and residential homes. I don't know what the current situation is in terms of the average that people are living, but certainly sort of my sort of personal knowledge of at least one home, you know, there are an awful lot of people living a lot longer perhaps than they used to. And are we actually really being realistic to expect that older people who are very elderly and cease to be able to look after themselves, we can manage the numbers in a residential and care setting? Because ultimately, if they're not in a residential nursing home, they'll be in hospital. So it's a very difficult balance. So given an expectation that we can artificially massage people down might be a bit unrealistic. So perhaps a bit of narrative on that, because it is what it is, unfortunately. And, you know, we've got to care for people, haven't we? Thank you, Chair.
Can I just say, in regards of nursing home, nursing care, residential care, etc., we've realised that the market and what we actually need maybe need a better look on it. So we've extended the contracts that would have come to an end in December for 12 months, so that we can go out, consult, both with the people that are running care homes, with the users, and basically know what we need for the future before we recommission those services. And that to me is really important, because we certainly don't want to be recommissioning too much of one sector when we in fact we need a different sector. So we're going to use this next few months, certainly, you know, I think probably up to about April, May time, to get that information before we let the contracts again. But Emma can help you with the other part as well.
So we've got a full item on dom care later on the agenda, but in terms of workforce recruitment and retention, there's some really positive work through our health and care skills partnership in the city, which you hopefully will have seen around and about in terms of social media and presence in the city. And we are seeing, we would say, reduced pressures in terms of the workforce in domiciliary care. It is still fragile, and we still need to make sure we look after those providers and that workforce, and really encourage people to want to come into that as a career option and to stay in care, because we know that the sort of cost and the time it takes to recruit new people is an extra stretch on our agencies. And so it's better, but we need to keep a close eye on it.
Thank you, Chair.
John?
Thank you, Chair. I found, as a sub today, I'm finding this really interesting. I haven't had the information beforehand, so thanks for that. But can I ask 3 questions? One perhaps links with Patrick's. Domiciliary care, does that likely, the demand on that, is that likely to increase over the winter because of people, maybe older people having falls or injuries such the like, and they'll require some temporary care? The other question is, what capacity is there in the city for, we've mentioned about longer term capacity for people who need, elderly people generally, who need care. What capacity is there for current people in care, knowing that there's one home will close in January and possibly another in the city? So what's the capacity for rehoming some of those residents in the city? And it's great that the number of people, the percentage of people who are leaving reablement, that's a new word for me, and needing aftercare is dropping. Can you explain why that is happening? Because that's a good thing.
Can I just say, we were advised on Friday of the closure of one home, as you just mentioned, and certainly we were very mindful there were 20 people in there that needed to have their fears allayed and be consulted with about where they wanted to go. So in fact, Emma can update you that our staff went in yesterday to the home itself to make sure, to start the conversations. because obviously January, well, it's not that long away, but you know, they need to start those conversations, and I'll leave the rest of those bits to the people that got the figures.
Thank you.
So in terms of domiciliary care, we do anticipate that demand for that will go up over the winter months. It always does. And also we do see some more strain in the workforce with seasonal bugs and things. So we know that's a problem, but we do know there is capacity in that market. Our waiting list is actually, just to trump Rob, down to 15 today. So it is coming down all the time, and the waiting times are at about 3 weeks on average. So people are getting the care they need through domiciliary care quicker, which is really positive. So we're confident with some of the measures that we're working with ICB colleagues on to build extra capacity in over the winter, that we'll be all right. It's be famous last words now, won't it? In terms of longer term capacity, we've done an exercise to write market sustainability plans for our key adult social care care sectors, which try to look further ahead. We've been in such a reactive space the last few years with COVID, and we want to get out of that into a really proactive looking ahead, working more closely with our providers so we can help them to have what we need in the city and adapt their provision accordingly. That's working well. We've got a lot to do. We've got the care home piece of work. We want to do a really big piece of work around our domiciliary care contracts as well. So we're building that capacity as we go, but it does take time, and getting it right, getting the beds in the right place, the providers that we really want to work closely with in the place that we need them to be. It's all ongoing. And just to say about the care home that you're referring to, staff are, I think they're actually going out next week, but they have been in daily contact with that provider since then, and providing support around how do we reassure staff, how do we reassure residents. We're working already closely with Live Well around who are the clients in that home and how can we support them to make sure they feel safe and that they've got somewhere to be. So really positive conversation with that provider this morning. Yes, very much in touch. And that's what we do in those situations, is we will wrap around those providers. First of all, to try and find if the situation is salvageable, if the home needs to close. If not, to try and find alternatives, either for the buildings, but absolutely the priority is for the clients and the staff. And then the reablement one.
Yeah. I'll pick up. I think your question is just something to make sure is that you think you've seen an improvement in the figures here, and why is that? What you'll find, I think generally the numbers will fluctuate up and down in terms of just depending on the sorts of people that go there. But you'll start hearing later about a lot of the work we're doing around winter planning, but certainly some of the work, a lot of those people are leaving hospital, and there's been a lot of work going on to get people's feet on the right pathways. So if we get people's feet on the right pathways, what that should do is maximise their ability for independence and to be re-abled. So I think what you'll start to see is a bit of the fruit of that work coming into our figures, and we'll hope that's the case, and then we'll keep working hard to make sure that that is the case, because that's better for people and it's certainly better for services as well.
Okay, I just follow that. So has there been a change in the way organisations have worked in order for the people to leave the hospital better placed, and also the Monkold Reablement Centre probably has helped a lot as well?
So the numbers that you're seeing here are what we call coming through our Home First pathway, which is that people going home, and we're trying to maintain their independence in those settings. So when you say changes to the way we've worked, I think what people are working hard to do under the pressures that there are with hospitals is to make sure now we're putting that extra effort in to make sure that people are leaving in the right way. Right. Because sometimes when it gets really pressured, there's a slight risk occasionally people will leave in the kind of a second option, if you like, in terms of leaving hospital. There's a lot of focus to get people home. The capacity coming back in the domiciliary care market, which you've seen, means that there's more flow in there, and that makes all of that possible, if that makes sense, because these aren't discrete, everything knits together in one nicely complicated set of circumstances. But certainly as the dom care market goes up, people move through faster, they move through that, and then you've got more people going into the right pathways, which is why that's so important.
Thank you.
Lindsay?
Thank Chair. I was initially actually going to ask your question about the waiting times, so just to echo how important I think that is. Yeah, also coming in as substitute, very interesting, thank you. I wanted to ask about, I think, correct me if I'm wrong, you talked about the direct payments were coming up, but we're still lagging behind the regional and national figures. And I wondered why there was that lag behind both regional and national, and also what we can learn from colleagues in this region and around the country to improve further.
Yeah. Okay. So the we are closing in terms, so we have been improving, so the gap between ourselves and I said regional and national, but it's actually also our group of most similar local authorities that we also sit behind as well. So we've known that it's been an area that we need to improve in for some time. I think if I was sat here probably 12 months ago, the gap would have been around about 7 percentage points. It's now, I think it's like 2 or 3. So the gap is increasing. That will be driven by conversations that I had within the service that determine, and Gary will be able to articulate this much better than me, but will change the approach towards direct payments. You know, there will be an active drive to ensure that they go up appropriately, of course. You know, we're not chasing targets here. If it's not if it's not appropriate, it's not appropriate. However, there was definitely, the figures were telling us that there was something that we weren't doing right. And that is what will have been the challenge facing Gary, and seems to try and improve that. The slight decline that we've had recently we'll need to look into, because obviously that's going to pull us away from the regional targets. Because it's we are able to benchmark this indicator because it's a national indicator within the adult social care outcomes framework. Therefore, it's one of the basket of indicators that gets published, that everyone who wants to can see how we perform against other areas. That's again why it's a priority for us in doing that. I'll let Gary speak in terms of the response in a minute. What I would also say is that we attend a lot of regional meetings within the Southwest, ADAS run groups, and within there are often conversations held and learning across local authorities, both at a performance level, but also at a senior management level that Gary and Emma would attend. So there is that learning at that level. Gary.
I'll just add a little tiny bit to that. I said earlier, everything's linked. One of the challenges we had probably 18 years ago was the domiciliary care market resources. People had worked really hard with the pandemic, and we were losing staff, and it was hard to recruit. So we created people waiting longer for domiciliary care. So what you can't quite see on here, but what you'll find is then other services stepped up. Direct payments, that's one of the reasons why direct payments started to increase, because another way to support people, if you can't get your regulated care workforce, and that's tricky, is the use of direct payments. So what we've seen is a nice gradual increase in direct payments based on some of that and the necessity, which gave it more focus for our teams, which is really fantastic, and it's grown. What you've now also seen is the domiciliary care market recovering a little, so you've then got to go and nudge the direct payment bit around maintaining a priority and a focus on that, and I suspect that's what then lies underneath that, and that's the kind of work that you need to do, because clearly what staff who are out there working with people's primary focus was, let's make sure we can look after people, and if one market was a bit tougher, which it definitely was at that point, you go and exhaust the others to fill the gap. To do that, you have to create the PAs and all the other people to come and support it. So it's not just as simple as giving people money and they're sorted. You've got to stimulate that market, and that's the other bit of work that happens underneath that. And occasionally that you get to levels and it plateaus, and so you have to keep working hard on it. So I think that's just the bit I would add really to the answer.
Paul?
Thank you, Chair. Just a bit of clarification. What is the exact difference between residential care and nursing care? Is there an overlap, and do people move one way or can they move both ways between the two?
Yes to all of those. There absolutely is an overlap. So we have homes that provide residential care, we have homes that provide residential and nursing care, and provision that provides nursing care. And absolutely people will, as their needs change, move between the two, really. So yes, there is absolutely an overlap in that, and it just flexes depending on people's needs.
And of course, you've got extra care thrown in there as well. Yeah.
John?
Can I ask a question, but talking about capacity? As when new housing developments are planned and started, such as Sherford or Palmerston Heights, obviously provision for schooling is included. What consideration is given to accommodation to accommodate older people who will need care? Because that way you'd end up having, as communities are growing, there's an opportunity for relatives of those families who may need to be closer to their family to reside in the community where the wider family lives. What mechanism is there for that to be included in the planning stage? Thank you.
Basically, we need to go and ask that question, I would suggest. And certainly if you're looking, I think we're going to be looking at the joint local plan again soon, aren't we? So it may well be that that's one of the, and Patrick with his hat on for planning, I'm sure knows the answer to this, but you know, to me, it's got to be something that's there, as you say, having that network around people. So Patrick, I defer to you and your knowledge.
It's certainly, John, covered under the joint local plan, so particularly strategic sites like Sherford and like Palmerston Heights, the bigger ones, you're looking really at a development that caters for all sections. So the housing service in Plymouth will identify numbers generally that they would like to achieve in terms of, you know, specialist housing, and then they look at those big infrastructure sites in particular to try and have a broad range of housing, so you don't just have one type. But equally, they're small schemes, and there's one that was a council site in St Maurice I use as an example, where there's, I think, 4 or 5 units of specialist accommodation just being built on that site. So there's infill development, but those strategic sites, they look at a broad range. So Coypool, for instance, we'd be looking at sort of apartment block that will cater for, you know, the needs of older people, and then you'll have 3 and 4 bedroom properties catering for families and so forth. Hope that answers it.
Has anybody else got any more questions? Emma?
Yeah, just to say, we're doing a very specific piece of work at the minute on a sort of specialist housing needs assessment for adult social care and for children as well, actually, working with Community Connections colleagues to look at very specifically what do we need for our different cohorts in the city, including our children who will need adult social care, our more elderly residents, our younger people, sort of the end of the age of 60 with learning disabilities, etc. So that piece of work is ongoing at the minute, and that will help as well, I think, to feed into future plans.
Okay, can I just ask Emma, what about our veterans, our service veterans? Are they included?
In everything, yes, absolutely.
Has anybody else got any questions? No. Emma, can we just have an update on the finance? That would be good. Oh, sorry, is it you? Sorry, Helen, sorry.
Okay, so in your packs you'll have the budget monitoring report for Q1 for adult social care. So at month 3, adult social care is reporting a pressure of 1.298 million. This is being driven by demand and cost pressures within care package budgets, and there's a breakdown in the table there. So the largest pressures are within dom care due to the reduced waiting lists and improved capacity to meet demand, and long stay nursing with increased complexity of need, which drives higher package costs. So the total pressure from care packages is 3.499 million, but this is offset by additional income from clients, but also it was recently announced when I wrote this, the Market Sustainability Workforce Fund grant of 1.9 million, which has been announced early so people can plan for winter pressures. So that's offset our care package pressures. So behind this, there is potential risk for further growth in these package pressures, but there is a lot of work ongoing to identify mitigations. So there's been a lot of deep dives into the big care packages and challenge panels. So with the service, Live Well, finance and project and performance officers, and these challenge sessions have been used to identify and drive savings to mitigate increases. We're also maximising income streams, so any additional grant funding or funding from health. And there's been a revised scheme of delegation with much tighter financial governance. So also within our budget, the service has a savings target of 3.712 million. The table underneath shows how that breaks down into on track. So all our savings plans are on track at the moment. We're not reporting any as undeliverable. And actually, since this report, we have moved a lot more into sort of achieved savings status. The risk is that some of our delivery plans are sort of centred around package reviews. So obviously, that would be dependent on the needs of individual clients as to whether we can make savings in those areas. But at the moment, yeah, we're not reporting any shortfalls on delivery plans. Any questions?
Any questions? John?
Thanks, Chair. Just looking at the respite figures, it's quite interesting because only 2/3, it's a relatively small amount of money, but only 2/3 of it has been spent. Is this because people aren't requiring respite, or is it because it isn't available, or is it because other bits of the service are working better now with shorter waiting lists for domiciliary care and appropriate placements that we don't need so much respite? It just stands out when you've only spent sort of 2/3 of the budget, even though it's small and only the first 3 months.
Yeah, so I think in that budget there were very few clients actually in that budget. I think more are in short stay nursing. I don't know if Gary or Emma, you wanted to add anything about respite?
I think I would just echo the answer you're giving, really. The numbers are quite small, so it just might be that some of the things we expected in those small numbers haven't happened yet. And there are two approaches in terms of our support. Sometimes it's respite, sometimes it does turn into be a short, what we call a short stay, which is slightly technically different from our point of view, but you'll see there the numbers are a bit different, so they could offset. Okay.
Any other questions? Okay. Can I just ask the committee to note both reports? And I'd like to thank Rob and Helen and Emma and whoever's contributed to that bit. Thank you very much. We're going to move on now to item 6, which is no right to reside. And Gary, you're going to give us an update.
I think this is normally a very brief update in terms of where the numbers are at the moment. And I think I'll just point out in terms of Rob's charts, whilst they show slightly, we all show the data in slightly different ways. What it shows is a really gradual improvement over time, which the trend continues to be, recognising it can go up or down through that line. The numbers, the average for October was at 11.4%, which I think is a slight improvement, although there have been ups and downs through the whole process. I guess the optimistic part of me wants to also talk about there was a really focused, what we call MAID event, because that had happened through last week and the weeks running up to that, which got us down to the 7% target, and actually did get us to the 7% target for that week, which does show that there are moments with that focus we can really kind of impact these numbers. I suspect they'll crawl back a little bit after, but overall I think we're really pleased with the hard-fought progress around those numbers, but we want to get to the target of 7% for our system. So it's still hard-fought for the teams, but good progress is the thing I would say.
Check, Gary, it might be quite useful, especially when we've got the substitutes here, to explain what no right to reside is, rather than they're thinking we're shipping people out here, there and everywhere. I think it might be quite useful. Thank you.
Can I bring Chris, who was more of a resident expert on that?
Thanks. So no criteria to reside is the measure that we now use for counting the number of individuals who are occupying hospital beds, so within Derriford, who have reached the end of their journey within the hospital, so they're now fit for discharge. And what we're counting there is people who've been termed fit and have been fit for more than 24 hours waiting to be discharged. So it's those cohorts of individuals that we're describing. I think, as Gary says, the number does fluctuate a lot. It is a challenging position. The hospital system has been under immense pressure again for the last few weeks, and you'll hear more later on when we give you an update around the winter plan, some of our intended actions around this, of which the no criteria to reside in, building on the progress that's been made jointly between Plymouth City Council, ourselves, and Live Well and other colleagues in the system, have brought down to bear on that, but to making sure that we can sustain that as we move into the challenging winter period. It's also worth recognising, Derriford serves a much bigger footprint than Plymouth, so we obviously also work really closely with our colleagues in Devon and also Cornwall too, to make sure that we're continuing to work together to move individuals from those areas back as soon as it is right to do so. And as was mentioned earlier in terms of some of the reablement focus as well, and again you'll hear this later when we talk through the winter plan, our absolute focus moving into this winter is that we make sure we're getting people onto the right pathway. So where we've got people who are ready to go, that we're maximising the opportunities for those people who can go home. If they need to go into a bed, that we do that in the right bed so that it's really focused on supporting them to recover and get them back home as quickly as possible, and that where individuals then need to go into a long stay because of their particular needs, that we can offer the choice and get them into the right services for them. So it's a complex picture, but one that we're really keen to make sure through our winter planning that we're doing in the right way so that it gets the right outcomes for people.
Thank you, Chris.
Thank you, Chair. My question is about the right to reside. Do you have times when actually it fluctuates during the week? I'm thinking particularly of weekends where it seems from my own experience, if somebody ends up being admitted on a Friday night, they're likely to be there until a Monday because there's not the facilities or the people that can make that decision. And is that planned for? You were saying about if somebody needs to go on to long-term care, is that thought about earlier in the week so that you can they can be moved before the weekend and therefore they're not sort of sitting there taking up beds when we know that the weekends can be a particularly busy time? Thank you.
Thank you. So yes, absolutely, we do see that fluctuation, and a big piece of work that we're working with colleagues in the Hospital Trust at the moment is actually how can we level out some of that. So how can we predict the numbers of individuals that are going to need to go at the weekend and make sure that we've got the right resource in order to move them through. The other big shift that we're doing is working with the hospital now are setting estimated discharge dates for people when they're coming in. So being really clear that we've got a plan to work for. So you're absolutely right, people will become fit over the weekend, but actually we need to be planning right from the point at which they come in. What's their journey going to look like, and how do we support them to get out as soon as they're able to, and start to level out some of that. And we have seen real improvements locally, and actually Derriford is in a strong position compared to comparator areas around that, the proportion of people that come out the weekend compared to in the week, but we know there's much more that we need to do around that.
Kathy?
Thank you, Chair. Gary, when you were referring to percentages, what exactly was the percentages of?
I'll probably answer better into that one. So the percentages, it's the percentage of beds in the hospital that are occupied by individuals who shouldn't be there, basically need to go.
Percentage of the total beds in the hospital, or the discharge, or the people that are being discharged?
The beds in the hospital.
Thank you. Thank you.
Okay, is there any more questions? Thank you, Gary. Right, we're going to, thank you, Chris. Going to go on to item 7, which is analysis of local government and social care ombudsman annual review letter 2001-2022, and that's for you, Rob.
Thank you, Chair. At the last committee meeting, there was a brief discussion on LGO complaints, and the outcome is the agenda item today. We'll hopefully go into a bit more detail for you. What I will say before I start is that we just recently received our 22-23 LGO annual letter, so I'm more than happy to pull out key findings on that as well in direct relation to adult social care, and either, it's up to you, come back to a future meeting or share it electronically. It's just to let you know that there is, we have just recently received that letter. Just for information, the LGO at the final stage of a complaints process if a complainant is not happy with the initial outcome, and the LGO make decisions on complaints about councils and adult social care providers in England. I'll just pull out some key findings from the report, which starts on page 41 of your pack. The average number of all complaints that the LGO received relating to Plymouth City Council each month remained similar to the previous year. So this is in 21-22. It reduced slightly from 7.33 per month to 7.25 per month in 21-22. I can tell you, just to give you a hello? I think we're okay. Just to give you a snippet from the 22-23 report, that's actually down to 6, so the latest figures will show an improvement. Adult social care is the third highest category of service within Plymouth City Council, against which an LGO complaint was started. There were 15 complaints relating to adult social care in 21-22, and this equated to 17% of all complaints that the council received that went through the LGO process. For information, the service that received the highest was environmental services, and second was educational services. That's 17% of all our complaints that are adult social care, compares to an average of 16.6% within our SITFA group of similar local authorities. The upheld rate in Plymouth for all LGO complaints was 73.3%, and that's of just 15 that were subject to a detailed LGO investigation. Plymouth City Council has a 100% compliance rate, and that's compared to 99% for similar local authorities, and this has been maintained in 2022-23. And what that is effectively, that is effectively the LGO saying that Plymouth City Council have successfully implemented their recommendations in 100% of cases that have gone through to full investigation. Pages 45 and 46 in the report present some information on those LGO complaints that relate to adult social care that were upheld, and where appropriate, the actions undertaken in response to those recommendations. I hope the report that you have does provide this committee with the assurance that we do track, analyse and implement the recommendations that when it comes to our LGO complaints. But obviously, I and colleagues are happy to take any questions that you may have with regard to LGO complaints relating to adult social care.
Patrick?
Yeah, thanks, Chair, and thank you, Rob, for bringing the report. It is a general point, Chair, if I may, and obviously it relates to adult social care in the round, but it's the way that the local authority actually handles the complaint and what member oversight there is in terms of the process. And I ask this because obviously over the last few years I've fulfilled a number of different roles, and certainly in the last 5 years I can't ever remember as an executive cabinet member ever having anything elevated to me in relation to ongoing complaints to the local ombudsman for areas that I might have been responsible for. But going back 20 years ago, I can remember actively being involved in complaints from those living around the Plymouth airport, around noise engine testing and complaints to the local government ombudsman. So my question is, a general one, of what involvement, I suppose, for adult social care does Councillor Aspinall have in having some oversight of the ongoing complaints and the way we close them out? And I don't know, Rob, if you know from a council-wide view what other cabinet members would have oversight generally on the process. The reason I ask it is that I think we should strive for continuous improvement and strive to minimise the number of ongoing complaints with local ombudsman, not just be functionaries in a process, and once we're told off, we actually pay up or do whatever the ombudsman wants. We don't really want ombudsman's complaints, and the more that we're seeing, I suggest, Chair, as a normal councillor, the process is more functionary these days. You can't talk to people; it's all online. You fill in a form, so we're all transactional. But transactional business doesn't actually always resolve complaints. So that's the reason I raise it, because sometimes you have to have an honest discussion in the authority, not have officers defending the authority to the hilt when it's indefensible, and actually sometimes settling complaints before they ever progress through the ombudsman's process. Thank you.
Thank you, Councillor. I'll just give a quick response, read the corporate process. So it is a corporate KPI that all departments monitor, but you're quite right, that's just numbers of, and numbers are low, but that information gets shared via scorecards each month with regards to numbers received and any outstanding issues that are come from the intelligence that sits behind a particular complaint. In theory, and I say in theory because I'm aware that departments take different approaches, but any issues really there should really be going through portfolio holder meetings, so it should be being talked about from a performance perspective, and then any response to that. Now, I can't sit here and say that everyone's doing that and taking that same approach, so it would be wrong for me to do so, but I'm sure Gary or Emma will talk further on that.
Sorry, I was reading a couple of those complaints there. The complaints that you've used as examples, every single one of them, it says that we gave them an apology. Do we think that really that is suffice? And I'm being quite serious on this, because how many times over probably all of us in this room have had an apology and it didn't really mean anything to the family. It don't really mean nothing to me. It don't really mean nothing to a family. When something has gone wrong with their loved ones, somebody saying sorry to me doesn't make that right. So do we think that that suffice?
Thank you, Chair. What I would say, it's they do also apology, which I think is a given in most of these cases. It's not just an apology. So there's in the examples that are in the report, there's talk of financial redress, there's talk of provision of training and guidance to staff, reassessment and various other things that go on. So I think an apology is absolutely on its own not sufficient, but I think it's a given that we would provide that as part of the response.
Okay. Emma?
Just to say, in terms of how we approach complaints, we do try very hard to have conversations. I totally take Councillor Nicholson's point that this can become very process driven, and certainly in my service, officers will absolutely speak to people, go out to see them if that helps, if they want to talk to us, because you can't exchange proper information on an email. You need, or a phone call even, you need to sit with someone and get that information face to face. So we do try as much as possible to do that.
And Chair, just taking that the last example here is talking about blue badge application. So I'll take that back and have that conversation with the blue badge team basically, although I know most of it's done out of the city, isn't it, these days? You upload to a national thing, so but I will try and get to the bottom of that one, because that's not acceptable if something's going wrong there on that system.
Thank you, Mary. I've got Natalie.
Thank you, Chair. Yeah, mine follows on from there. You've said about the apology and it says financial redress. Obviously, you're not going to disclose sort of amounts of money, but you know there is that concern that money has to be budgeted for here somewhere for this money. So obviously we need to be reducing complaints. One, because obviously whoever the family, the client themselves, or obviously something's gone wrong which has affected them. But actually, from a financial point of view, we don't want to be having to be in a position where we're actually having to give money out for something that perhaps shouldn't have happened. And so I have queries on that. How much money are we talking about here? How is that budgeted for, or is that something that's actually pulling away from other very much needed services?
I'd have to go and find that, because I'd be interested to know how much in the budget, if that's okay.
Thanks, Helen. Lindsay.
Thank you, Chair. I wanted to make an observation around what we're talking about. I was canvassing in, I think it was April, in Liam. And when I knocked on the door, the man who answered the door said, right, you stay there. And he was immediately very angry. It turned out that his wife had cancer, there'd been issues with her care, and he brought out to me a set of documents. Now, what these documents amounted to was an apology and admission of fault and a decision to make corrective measures going forward. But it was so long and so densely written and so couched in quasi-legalese that he didn't feel that he'd received an apology. He felt like he'd been tricked. He was absolutely furious. And I ended up going back there 2 or 3 times and speaking to him on the phone 2 or 3 times. And I think a lot of his anger would have been resolved if he'd been talked to like a loving husband whose wife was going through the most horrendous trauma of her life, which he could not help her with, rather than being talked to as though he was a potential litigant in a court case. And he needed me to read that letter for him and explain it. And it's a shame, because they were having the worst time they were ever going to have. And the only reason that they got somebody to explain the letter to them was they happened to be in when I happened to knock on the door. So it's an observation, that's all. But that's a story from one of my people in Liam. Thank you.
Chair, could I just say thank you, Lindsay, for that, because that's something I will take forward and ask who puts the letters together, and perhaps Gary, if you and I can have a conversation with the people writing these letters to see what restrictions they've got about how they can formulate these letters. So we'll get a bit more information on this. Yeah.
That's a very kind response. Thank you, Mary. Thank you.
They are quite standard templates, and I think you're absolutely right. The humanity can get lost in that sometimes. So it's finding the balance between the process and the people, isn't it? And absolutely, we hear you, and we will try and do better with that.
That's lovely. Thank you.
I just want to add to that, to the things, and if those people want to share that letter and we can have a look at it, I'm really, really happy to pick some of that up. We are and should not be transactional in what we do, because what we do is support people, and I think that's really important. If there's a feeling that there's a transactional part to that, then we need to know, because that's not what we are. We talk to people and we deal with people. Don't always get it right, which is why these processes are important to be there. And if people remain unsatisfied, it's right to go to the LGO to say, actually, that wasn't a good experience for me. I am also aware that the range of things we do is really diverse and sometimes very complicated, and you can be very personal, and sometimes you have to write it down, and I don't know what those letters are or who wrote them, but I do know some letters are complicated when you have to write down some of the things that we have to talk about, charging and financial assessments, for example, is something where sometimes the answers are really complicated. Even though you might have done the personable bit, I would certainly hope you had. So I think we still need to work with people to make sure there's understanding. I guess I'm just trying to describe the real breadth of things that we'll see. And that touches on the financial, because if someone's complained about something where there's an error, where there's money involved, it could be quite a lot of money that then has to come back. I think the report showed what the LGOs said they wanted us to do. And sometimes they say to us, make sure you apologise, we should always do that if we've not got it right. Then they sometimes will ask us to make sure there's financial redress. That goes in as another layer of showing how serious we are about that apology, recognising it's after the fact, isn't it? Getting it right is what you need to do. Yeah, and they normally ask us to do it. And actually, whenever we write a complaint response, we normally expect it to start with an apology. And it doesn't matter who's right or who's wrong. If we're in the complaints process, there's been a failure somewhere, hasn't there, in terms of a communication. So I think I just wanted to add those bits to it, because sometimes it's quite complicated what some of the things we do. So letters they're not an ideal way to communicate things, because they can be hard to understand and they can feel a bit technical, even if we don't want them to.
Could I just come back to that, because you're making a really good point, Gary. Perhaps if the complex part was at the back of the letter and the front of the letter was some form of précis in slightly more human language, and then backed by the legal side of it, because I completely understand the point you've just made. At the same time, I completely understand the point that this man was making to me.
Stefan?
Thank you, Mrs. Chair. One of the things that really concerns me is how do we deal with the complaints and how quickly we act upon them. I know of two cases. One is dealing with safeguarding, where we have a child that is living in a situation where mother and father are heavy alcoholic, but there is a solution within the family. The problem that they have there is the number of social care workers that have been going there to find a solution, and every time it's a new face, new face, new face, and there is no resolution. Now, the second thing is about the access to Blue Badge. I have a resident that is still waiting for her PIP.
Stefan, this committee isn't for casework, if I'm being totally
No,
honest.
I'm just highlighting the issue of dealing with not the casework in itself. I'm just presenting the cases, and I just want to find out how quickly we are dealing and what we are doing to learn from those experiences. So, this is just some of the caseworks.
Okay. So basically, how quickly do we deal with them? Sorry, Stefan.
It's okay, thank you.
So corporately, we have guidelines that we should respond within 28 days. And we have a corporate, I think that's right. hopefully I'm not wrong. And we have a KPI that every department is held to account for each month, the performance against their compliance to that. So what number of complaints are closed within that time period, and also what percentage are closed within that expected time period. So that's certainly the corporate approach to how we performance manage that area.
I just need to add to that. We do monitor ourselves on the 20 days. From an adult social care complaints process, one of our important jobs is to contact and talk to the individual and agree with them the timescales, because they're not all possible within those windows. But what the process says you need to do is work with that individual to keep them informed and let them know, and agree with them a date by which they'll get a response. We measure ourselves on 20 days because you'd like to resolve a lot of complaints as quickly as you can, but for some it is not possible. You mentioned safeguarding, for example. If safeguarding comes in, a complaints process goes to the side and a safeguarding process comes to the front, and we do that before we do that, because that's what people would want, if that makes sense.
Mary?
Can I just say that any safeguarding issue should be referred to the safeguarding team, whether it's adults or children. Doesn't matter about anything else, it should go to safeguarding if you think that there is a cause there. And in regards of a blue badge, then that needs to go to the transport team. So I think it's a case of liaising with the cabinet members who have responsibility for that particular case in the first place, so that they can help guide you on that. But certainly it's a minefield, but these are complaints that have come in further down the line, Stefan, that have obviously not been dealt with on a councillor level first, and then they have gone on to the next stage of the complaints in many respects. So I think, you know, we as councillors, if we can do our casework, I'm not going to say correctly, but if we can do it appropriately, then that might help with some of this. But always ask for help. Don't sit there thinking, go and see, you know, talk with somebody. Okay.
The problem that I have there is that people said the council is not doing their bit, and this is the issue. So I'm just raising to find out what can we do, what can we learn from these experiences, so that we can improve the service and have more quick resolution to the issues that are there.
Again, I will come back to go to your cabinet member for whichever service it is. I'm sure all of our colleagues around the table that have been cabinet members will you know, agree, I hope would agree, that if you can't get anywhere, talk to the cabinet member with that responsibility, and they will help guide you.
Thank you, Mary. I've got John, and then I've got Kathy, and then we're going to just have to move on from this section.
Thank you, Chair. My point is really the object of these, the result of these outcomes should be that the areas are looked into, because these are the people who have relatives or somebody who have taken it to the ultimate complaint, which a lot of people don't feel capable of doing, don't want to do. It's a lot of trauma, and there are undoubtedly similar cases that don't reach the local government officer, you know, of similar nature, perhaps not as serious, but, you know, surely the object has got to be to look at these cases and actually see if there are any others that could have gone down the same route but didn't. And actually the whole area of care that's being referred to needs to be reassessed. I mean, do we actually do that? Because these are just the top of the pyramid, really, aren't there? There are other cases that are similar, perhaps not so serious, but people don't pursue them.
Thanks, John. Kathy?
Well, I'm just going back to the previous point, which has probably more or less been dealt with. But with regard to the letters going out, again, I was going to suggest a supplementary letter with the name of a person to contact, or preferably somebody who's going to contact them a couple of days after they receive that letter, so to discuss the contents, but actually, you know, have it in brief form so they know that it's a person, you know, legally, obviously, I understand that you might have to say certain things which they don't necessarily understand or appreciate, but you should be able to, you know, make it human as well, and have a supplementary letter by the side of it telling them who they can contact and who will contact them.
I mean, I don't know, do we put a name on the letters?
So we do put names on letters. We also, when complaints come, they're acknowledged initially to say, yes, we've got it and we're having a look at it. There'll be maybe office contact details at that point rather than a name. But then when it's assigned to an investigating officer, there's normally contacts and people know who that is. Again, it sometimes depends on complaints, but they'll know that, they know that information. But I mean, I think what we can do is we'll take some of that feedback and reflect it back in what we do.
Chair, in relation to the recommendation, could I actually move an amendment? Because I think it's pertinent that scrutiny seem to be scrutinising, and I know Councillor Mrs Aspinall and officers have very assiduously participated and listened to the debate, but I would like to add a second recommendation to request that the Cabinet Member for Health and Adult Social Care have oversight of local government ombudsman complaints in relation to adult social care. So a broad brush statement, I'm sure that'll happen anyway, but I think it would be important for scrutiny just to record that and be happy to move.
Very happy, Chair, to accept that, yes.
Thank you, Patrick. Thank you, Rob. Committee just to note that report. All in favour of the recommendations? Yeah, thank you. All right, we're going to move on to item 8, which is commissioning of domiciliary care, and that's Hannah and Emma. Yeah.
Thank you, Chair. So we wanted to provide a bit of a deep dive really into domiciliary care, give the context of what we have in the city already and how we know it is good enough for our citizens critically. Oh, I'm going to try and get this to move on. It's probably not going to do it. Ah, brilliant. So domiciliary care, just a few facts about what is domiciliary care up on the slides at the minute. So it's a really critical service for meeting the needs of some of our vulnerable adults in the city. If we deliver it well, it helps to keep people living in their own homes with dignity and independence, which is obviously a key driver for us. It is a sector that was put under significant pressure and impact by COVID-19, both operationally with all the changes in guidance and requirements around safety and all the restrictions that the service had to operate under, but also in terms of the impact on the workforce. We can't underestimate how absolutely exhausting it was for these workers to keep going through COVID, and we're forever grateful that they did. Since COVID-19, we have been doing a lot of work to sort of reset, move out of a sort of reactive space and into proactive and understand what we need going forward against what we have. Oh, I don't know why it zoomed in hugely like that. In terms of, sorry, I will sort this out in a minute. In terms of our current data, so we currently have 20 providers commissioned via the City Council, all on spot contracts. So that's something we want to address going forward because it gives us less control and influence over those providers, and we want to work more closely with them. We are in the process of looking at how we will redesign those going forward to sort of facilitate as much closer working relationships. And there's just some figures on there about the sort of scale of domiciliary care in the city. So 14,000 hours of care a week are delivered to approximately 1,000 adults in the city through the council. As we said earlier, that figure around 50 people awaiting a dom care package is now down to 15, so really going in the right direction. And you've got some figures there around what we pay per hour for this type of care, but also you'll see it's a significant part of the adult social care budget. We also talked about earlier that clients can use direct payments to bring domiciliary care into their own homes, and Live Well will support them to do that if that's the route they want to take. We know that some of our providers do support private clients, and it does vary significantly as to which providers do that, and we have less sight over that. But that can have an impact on the capacity in the city. This ties in really with both Helen's finance report and the performance report in terms of being able to see the increase since 2021-22 in terms of the growth of the use of domiciliary care in the city. It's a market we still want to grow, as we were describing earlier. Being able to support people to remain safe and well in their own homes is an absolute priority. So, and with some of the initiatives that Chris will talk about later with the ICB, we are anticipating more domiciliary care in the city, and we want to encourage more people to be able to stay at home. So this is a part of our care provision that we think will continue to grow, and we would like it to grow over the next few years as well. So in terms of how we know that this is good enough and as good as it can possibly be, Hannah's one of our lead commissioning officers in this space and is going to talk us through how we do that.
Thank you. So each provider in the city, regardless of how large or small they are, have a dedicated commissioning officer or assistant as their contract manager. We're always a point of contact for support. We have really regular conversations with our providers, whether that be through telephone calls, contract meetings with them. We do a mix of virtual and face-to-face visits, try and get out and see them as much as we can. We have currently we're undertaking in the department a review of the quality monitoring processes that we're undertaking for all of our care services, including domiciliary care, and this will form part of the new contract for dom care, as Emma alluded to. So if we have whole service concerns that are raised for a provider, then this will trigger a more intense monitoring process, for example, weekly visits to providers as opposed to fortnightly or monthly. Requirements of a service improvement plan. Those whole service concerns may come in through a variety of routes. That might be safeguarding. We may receive a number of complaints within a certain time period, or CQC might raise concerns with us, which will trigger that process. We also have an intelligence dashboard, which is held and reviewed on a regular basis by all of the commissioners, which again that includes CQC ratings, number of safeguardings, complaints, compliments as well, and our financial assurances that we can get through our procurement colleagues. We also work closely with our Live Well and safeguarding colleagues to monitor the safeguarding or any concerns that come through, and these are always addressed through our contract monitoring processes. That might be a joint piece of work with safeguarding or handed over to us in a quality monitoring aspect. We've just put some figures there in terms of our local CQC ratings against the national average. I will point out that the requires improvement, there are 4. Within the city we have 3. The 4th is technically registered in Devon, so whilst we do commission with them, the quality oversight is held by Devon County Council. But as you can see, we are faring well in terms of outstanding of the percentages, 17% against 5% national average. The requires improvement, the 3 in the city we are working very closely with, and they are not historical, but they're fairly moving on in their terms of their service improvement plans, so we're hoping they're in a much better position than they, of course, were when they were first inspected.
Thanks, Hannah. So I referred in the first slide to spot contracts. That is not a particularly effective way of contracting with providers. So we have contracts in place with these providers. They need changing, they need updating. We will be bringing a business case forward through Cabinet in the spring to describe how we will do that, working in partnership with these providers. We know to get this absolutely right and sustainable for the future, we need to be working very closely in partnership, not just with the providers, but with our clinicians, with the hospital, with ICB colleagues, with Live Well, and a whole variety of other services that support around these clients. We know that we want to involve our providers from the very outset in the redesign of how we organise domiciliary care in the city. We need to really be putting our service users at the people, not so, I hate the word service users, the people at the absolute centre of all of this to make sure the system is designed around them. We need to make sure as well, an eye on the value for money for the local authority, make sure that we are paying a sustainable and fair price for care that supports local workforce, that supports the resilience of the service, but also that we can afford. So one of the things we're kicking around at the minute, and this is by no means the final design of this, is how do we, given our geography in Plymouth, we should be making better use of localities in the city, and how do we align our services around our localities? And we've got at the minute, and the team are brilliant at mapping exactly where all the care packages are delivered across the city and which agency is going where. We have a number of situations where people are hopping all the way around the city to get to different people, and we think there's a better way of organising that so people have more of a sense of ownership of their patch, their neighbourhood, their community, and that very much ties in with all our work around our hubs, with Live Well's locality working, etc. So we want to really, through new contracting arrangements, really build on that community resilience and that sense of ownership in communities. So we're looking at a model, and this is all a bit commissioning a bit techie, so I do apologise, but where we do something around locality partners and how do we encourage our providers to take real ownership of their area and work with us around taking the lead in those areas to provide care. And then that won't be enough though. We know we will also need other providers to be able to flex in and out of localities. Because what we absolutely cannot do, it's an absolute requirement that our citizens have choice in this respect. And so we need to make sure we have enough choice, but not so much so that it just goes out of control. So it's getting that balance right. So we are aiming, as I said, to go to Cabinet in spring, contracts to, all being well with a fair wind, no pressure on Hannah, to be in place for the end of 2024. But it's a lot of work because we have to get this right and we have to describe this in a way that encourages providers to come with us, to want to grow, but we have to be so clear in describing what we need and how it will work. We have seen over the last few years, we get approached pretty much daily by agencies trying to come in from outside the city and set up here. In reality, all that does is staff just move around. It doesn't create growth. So we want to really get a grip on this and really create those true partnerships so that these agencies feel really supported by us and able to carry on doing what they do. So just a bit on some of the sort of risks and mitigations, some of the things that we deal with really. I've touched on it already, but geographical challenges. We do have providers working across multiple postcodes. Sometimes that's fine. Sometimes it just makes it really complicated and builds in more and more travel time that could be spent delivering care to people. There's also, we'll talk about this a bit more later, I'm sure, but there is a new intermediate care plan for the city, which Chris and his team are leading on, which will encourage further growth of domiciliary care. So again, we don't just want to carry on building what we've got, we want to change that. Budgets are challenging, as we touched on earlier, and one of the panels that Helen mentioned earlier specifically looks at domiciliary care on a weekly basis. I sit on one of those panels every Friday, and my team, various managers, sit on those panels through the week, where we are working very closely with LiveWell to double check every case that's coming through for extra resource, to make sure that we are doing the right thing, and if there's an ability to challenge any of that appropriately that we can do. It's a really useful exercise for commissioners. We get really down into seeing people's circumstances, the pressures for them and their families, but also how we're responding, and then we take that back into conversations with providers. Really critical for these group of providers is our health and social care skills partnership, and the coordinators that work in that partnership work really closely with our providers, with recruitment fairs, sessions at the job centre, and there's a Devon-wide international recruitment programme as well, so lots of work going on to try and build the resilience. We know that these providers can struggle with, they deal with a huge range of complexity. It's a really broad span of need, the people they care for. And so we need to make sure that we wrap around them. So if something changes, if they're worried about a client, that we have a complex multidisciplinary team process where we all get round and we all help and try and help keep them going. And that can include looking at training needs and skills for the future. So finally, really, we are really genuinely interested in hearing about people's experience of domiciliary care in the city, whether that's someone whose loved one is cared for, the person themselves, professionals, anybody really. So there's an email address there, and we would really welcome feedback that we will then take into our design of the service next year.
Thanks, Anna. So, Lindsay?
Sorry, popping up again. Thank you. This sounds amazing. This sounds really, really good for people to have that local care. I just wanted to, sorry, I'm probably teaching you to suck eggs here, but you know, whenever there's something that's local, people always say postcode lottery because there's a line on the map and the computer can say no, but that's built in. I used to work in IT years ago. If right at the beginning they build it up so the computer can be told yes, so that a bit of human common sense can prevail sometimes, it could make a huge difference. I'm absolutely sure you're already aware of that, but it looks so great, it would be a shame to not be able to be flexible with it. Thank you.
Anthony?
You on the last page you said you wanted some feedback. So how will people know that you want feedback? Obviously, you said service units, families, etc. Are you reaching out to those people or making it available out? You know, we think about Health Watch and things like that. You know, sort of out there trying to get feedback. How are we going to get that information and you know, ideas? Thank you.
You're absolutely right. A slide at Scrutiny is probably not going to cut it, is it? So, so as part of, we're literally at the beginning of that process. So yes, we will make use of council social media. We will engage with Health Watch. We're in regular conversation with them. We have provider forums. Hannah and the team are regularly going out to see people, meet them. So as much as we possibly can. But we would also welcome elected members helping us to encourage people to engage with that process.
Steve?
Thank you, Chair. Obviously, we do deal with these sort of issues with domiciliary care, I'm sure we all do as councillors in our communities. And I have pointed people that are having negative experiences to email this address, which is great. I just wanted to get a flavour of just the operational side of it. So that email, who monitors it? Who monitors it? How is it? Is it like impossible to keep up with it? I just wonder what the daily sort of churn was, the weekly, monthly, just to get a flavour of the usage of that email address.
So it's the one for the service, and we have a commissioning assistant on duty every day monitoring that. They are very good. They can answer most queries, but they will absolutely escalate to a manager if they're unsure. And so it's the flow into that is absolutely manageable. It was a bit more crazy during COVID, as you'd expect. So it's entirely manageable, and it has eyes on it every day.
I think it is great because sometimes people get very passionate about the situation and they just want to verbalise it, and we're all about conversations, but sometimes they've got to put it in an email so you can react to it. So I'll keep doing that, and it's good to have the service. Thank you.
And we want them to do that. These are people that experience care. It's ever so easy for me sitting in Crown Hill Court to say, well, we should do it like this. Actually, good commissioning comes from the people into commissioning, not commissioning down into people. So the more lively and furious, the better, as far as I'm concerned.
Patrick?
Thanks, Chair, and thanks for bringing the report. And certainly, I think it was something we were talking a number of years ago about. You know, you've got certainly staff crisscrossing across the city delivering services. It doesn't really make much sense, and they don't all get paid for travel. Some providers pay, and I think some. Do they all get paid now? Going back, they weren't always paid for travelling from A to B, but it is a very fragile area, Chair, and I think it's one that Scrutiny perhaps could have an update at the time you take it to Cabinet, because it's a very important area. And certainly for those that you're talking about entering the health and care profession, many of them will come through a domiciliary route as their first part of hopefully a longer career. Now, £22 an hour might sound a lot to an awful lot of people, but time you pay, probably the majority are on minimum wage or living wage, and then you take on costs, it's not a great deal in there. So I'd like to know, perhaps when you bring it back, Emma, a bit more about the contracting methodology, period of the contract. I don't know what a spot contract is at the moment. Is it 2 years? You know, if we want a true partnership, we need to actually offer a contract that will engender some benefits, you know, to the overall environment. And so, you know, many people criticise business because they have to make a profit, but if they don't make a profit, they go to the wall. And actually, the rates we pay in local authorities generally through a lack of government support are probably not getting the optimum that you would get out of the system. So I'd be much more interested in a bit more detail around that contracting method and whether it's sustainable or whether we're just imposing on the market the will of the local authority. Because generally, councils are criticised for influencing adult social care by the lack of money from government and the amount that councils pay. And that obviously has a disproportionate impact on the services that we can provide to the public. So I welcome that in due course. Thanks.
So just to clarify, that hourly rate is the rate to the agency, that's not the rate to the carers. So carers will be absolutely paid less than that. Spot contracting is, Councillor Aspel actually wrote spot question mark next to me a little while ago. It's not, effectively we have contract terms and conditions, but it doesn't commit us or them to anything. And you can't, for some types of provision that works really well, but for this, where we want absolute, if domiciliary care falls over in the city, the whole system collapses. It's, as you've rightly said, it's one of our sort of foundations of adult social care. So we are increasingly looking at, for key sectors, at longer term contracts to give the providers the stability they need to be able to take risks and expand, and also for us to be able to build those relationships over time. So more and more we're moving away from 2-3 year contracts, which by the time you've procured it, you're halfway through, and settled in, you're halfway through the first year. The year before the end of it, you've got to start re-procuring it. So you get there's no break to do anything meaningful. So yes, longer term contracts, moving away from spot contracts, committing to providers, and providers committing to us as well, critically, and any work we can do around helping our carers to be appropriately rewarded is a priority.
Thank you, Chair, and probably remind the government to give us more money.
Will?
Obviously, there's to increase the domiciliary care, you'll need more workers and people to be available for more hours. So, have you looked at perhaps taking it in-house so that the council employs people directly? And have you looked at provisions such as union recognition, so that those members of staff have people they can go to? Obviously, they're going into people's homes. I've heard anecdotal things, not from friends and relatives, where there's been an issue, and a carer that they've had lined up for a relative is said, "Oh, I'm not coming down there again," because of an issue that's come up that's not really to do with their pay or the terms they're employed under, but because perhaps there was another bit of support that wasn't there. So has that been looked at, and so that people enjoy the negotiated the other things that keep people in the proper pension schemes and whatever that other types of employees such as NHS or council employees enjoy, but not, unfortunately, it's not always with private providers.
Yeah, so we do. We have a Plymouth City Council domiciliary care agency called At Plymouth Care, which was set up in, looking at Gary.
So that's an arm's length, that's part of the family of companies of the council, not in the council. We do have a council run service, that's the reablement one that you saw in the performance figures that we've got. And we work really hard with all of the providers out there in the city around standards and levels of employment. And in fact, we did a lot of work in terms of the pay we've got to get it to the 2205 to try and help. We have to remember each of those are individual organisations, and some of those things are for them and how they create different, they try and be attractive to workforce by providing different sets and ranges of terms. They're not the same as NHS terms, they're certainly not the same as local authority terms, but they are kind of comparable in the private sector in terms of terms. Councils nationally, I think it's fair to say, probably quite a long time ago, took decisions to not provide all of those things. The arm's length, the family of companies at Plymouth Care is something we did through the pandemic because we were trying to support the market, which was failing. So as it failed, we took a few companies in and we built it. What we've done is learnt a lot with that, and I think that's the process. So we pay it the same as all the other providers, and it has to wipe its feet and do all the challenges. So that is a really helpful process, and some of the learning from that can feed into the work that we do to kind of help inform the wider market position, if that helps you.
And just regarding the unions, I have a meeting every quarter with the unions to talk about commission providers. And as Gary says, it's for those organisations to make their own arrangements, but they will share intelligence with us about any concerns they're having around any of our commission providers, any feedback. So we know that an increasing number of the agencies in the city are engaging with the unions, and there is a direct line back into commissioners, so we hear any concerns about how staff might be being treated in terms and conditions. So obviously there's a limit to how much we can influence that, but when it affects the contract, we can absolutely step in there.
Mary?
Just to reassure councillors as well, there's been something in our local government daily things that have come out about human trafficking and care sector, and that is something that we are making sure that we're monitoring for and taking into consideration, especially because we have been doing some international recruitment, so it's really of prior importance as far as we're concerned. So I would like to, I say, try and reassure you that we are taking that sort of thing into consideration.
Thank you, Mary. John?
Thank you, Chair. I really welcome this model because it will enable, if a care worker or care workers in a locality got to know their area, there's an opportunity then to advertise and promote involvement for those care workers in community engagement, such as lunch clubs, friendship groups and so on that are local. If care workers are sticking to a locality, will they be expected to see more carers, people in the service users during that time, or can some some people who require care have more time than they currently have now based on their need?
So it's always based on their assessed need as to what they need. We do have a number of carers who are walkers, so don't drive, and bikers, as Councillor Ashmore says. So this will hopefully enable people to be able to get to places in the way that best suits them. So it suits the carers as well as the clients. We need to look at that. What it cannot do is lead to a deterioration of care or as trying to cram more and more things into it. And you're absolutely right about the connection with community services. So thinking about our day centres, thinking about all the amazing VCSE community clubs and opportunities and befriending activities. There's a real opportunity here to help with loneliness and isolation. And if people have that sense of, oh, have you thought about that club on a Tuesday around the corner? You know, perhaps, you know, there's real opportunities through this, we think.
Thank you. Just following on really from what John has said, my concern already was, we talked already about recruitment and how we don't want to lose staff. Obviously, some of these agencies will have staff that are happy with that agency and are working for a particular reason in that area, and it may well be because they're in walking distance, etc. If that agency then ends up with a contract in the other end of the city or in an area that doesn't work with those staff, you know, then we've got displacement because, you know, where are they going to go?
And that's exactly the reason why we're taking a bit longer to do it, because what we've been talking about is we cannot do this as a big bang for precisely those reasons. We cannot disrupt, you know, the relationships that people have with their clients, the relationship that carers have with their agencies. So what we're talking about at the minute is how do we do this in a phased way, because that would be awful to come up with a brand new design that then just throws everything up in the air. Yeah, overnight. So it's going to be very complicated. And poor Hannah is tearing her hair out slightly with it, but that's a key factor for us.
I think it's a really, really important point though, isn't it, in terms of what we're trying to do, because our ambition is to improve and make things better. I know, having spoken to a lot of carers, they will tell you about their frustrations at having to drive sometimes on what they will feel are quite illogical care routes and things. So we know those things will make it better, but we also know the transition plan, it's kind of evolution, not revolution, isn't it, is the thing for us, the transition plan, to make sure, one, the people that we're here to support get the continuity they know and deserve and are part of that change, but two, for our carers, as that starts to happen, it happens in a way that engages with them rather than makes them feel like they're, you know, that fed up, because that's really not the plan, and would not be a desire for us in any way.
Chair, and just to make sure everybody realises that this isn't just older people. We give care to those young adults as well as you know, middle-aged people that have needs and whatever. It isn't just based on older people, so they do need to have that continuity and that knowledge and whatever and understanding. So, yeah.
And it's similar. Some of these are providers who deliver this type of care for our children as well, particularly children with very complex disabilities. So, yeah, whatever we do cannot break this. It has to make it stronger.
Okay, just a quick yes or no answer. When the care providers have their inspections, are they notified that they're going to get inspected?
So in terms of our visits, in the main, yes, we do tell them unless we turn up. However, obviously CQC wise, they're unannounced. We do, within the terms and conditions, we can turn up unannounced if we think if we have quite significant concerns, then we will approach the office without letting them know. So obviously they are unable to prepare, etc. But yes, in the main, we will work with them to let them know we're coming.
Okay, thank you. So CQC don't let them know? Unannounced?
Unannounced, yeah.
Don't say they were going to visit you next week at some point?
As far as I'm aware, no.
Okay. Okay. Thank you all very, very, very much. We're going to have a break now until 4 o'clock, and the reason we're going to have that break is because we have got Alex Deacon coming in to present for us, but they can't get here until 4 o'clock because they're working in between surgeries. So it's really important that Alex comes in at dead on 4 o'clock, unfortunately. So, and I don't want to move on to the next part of that report because we might be halfway through it, and then we've got to stop because Alex has got to do this at 4 o'clock. So I think the best thing for us to do is just to take a quick little break. It's only 15 minutes, little 15-minute break, and we'll come back at 4 o'clock, but dead on 4 because Alex will be presenting at 4. Yeah.
Just before we run away, Chair, thank you. One quick action for the committee to note that last report, and I wondered whether we wanted to consider some form of recommendation about when and what content we bring back, as Councillor Nicholson proposed for the domiciliary care item. Do we want to put in a timescale and content?
Yeah, I think we are probably looking at once it's been to Cabinet for the Cabinet's decision, then we'd be very happy then to share it then at the most appropriate time. Yeah.
Quick 15-minute break. Well, it's not 15 minutes. It's not going to be no quicker than 15 minutes, but do you know what I mean?
Quick 15-minute break, back in 10.
Hello? Can we all settle down, please? Because I know this is really important for Alex, because he's actually coming in between surgeries for us. So we're on item 9, and we're going to have Alex talking to us about the National Seasonal Immunisation Programme. Over to you, Alex. Thank you.
Well, thank you ever so much. Thanks for having me, and thanks for accommodating kind of my timings. As you can see, I'm in surgery at the moment. So for those of you that don't know me, my name's Alex Deacon. I'm a GP in Mid Devon and the Primary Care Medical Director for the ICB, and I'm also the Senior Responsible Officer for the COVID vaccination programme. So I know I've sent some slides through that I hope you've all seen. I'm not planning on going through them all in detail, but I thought I'd pick out some kind of key things for you and then give you an opportunity to ask any questions or comments. If I don't have any answers, I can certainly take them away and come back to you, but hopefully I'll have answers to any questions you may have. But the seasonal vaccination programme is led by the ICB. It really is kind of a system effort. We've got the local authorities involved. We've got our primary care networks, our GP practices. We also have the NHS England screening and immunisation team and infection control and medicines optimisation involved. And all of these people together work collectively to put on the vaccination programme. You may know there are 31 primary care networks in Devon. It's not compulsory for PCNs to be involved, but we have 19 across Devon. There are fewer down in Plymouth who are involved. Mainly, I think, because primary care in Plymouth is probably under greater pressure than some other bits of the county, so it's a bit more difficult for them to commit to it. But one of the good things this autumn is that actually we got a bigger offer from community pharmacy as well. So I think we've got over 50 pharmacies across Devon. I don't know the figures for Plymouth itself, but we've got far more community pharmacies that patients can drop into, and some of them, I believe, do kind of walk-in COVID jabs as well. One of the other things that actually we're quite proud of in Devon is that we've got a really good health inequalities cell who looks at kind of the inequalities or kind of bits of the population where uptake is lowest, so often related to things like deprivation or things like serious mental illness. And I chaired our kind of monthly programme board yesterday actually, and heard lots of really good things that group is up to. So the delivery model for COVID vaccines in the autumn this year, we got kind of, we've had 3 large vaccination centres. I mentioned 19 PCNs, 53 community pharmacies. We've got 480 care homes across Devon that we need to visit, and which I'll come on to in a second. And also we're planning over 300 outreach clinics as well. Now, the uptake of COVID vaccines in Devon is exceptionally high. I think we're the best in the country, or just about the best in the country. There is some data in the slides, but it's a little bit out of date. I got some. Sorry, I'm just looking at my emails on my other screen. But now we're up to 50% of the eligible population have been vaccinated for COVID, 55% against flu. Another big thing this year is we're trying, where possible, to what we call co-administer flu and COVID. So those individuals that are eligible for both, we're trying to do it at the same time. Often one jab in each arm, sometimes both jabs in one arm. I had both jabs in one arm. But I think last year, or my experience of vaccinating was there was a little bit of reluctance last year, but this year people seem to be much more willing to have them both at the same time, which we know is safe and just helps with regards to workforce and resource in the NHS. Again, I know the slide isn't up, but we've already, as of the 17th of October, and this is out of date, we've done over 210,000 COVID vaccinations this autumn, and nearly 250,000 flu vaccinations. So that the numbers are really huge. I mentioned care homes. Devon is, I believe, the best county in the country for visiting care homes already. We've already visited 97% of the care homes across Devon, and I believe that we have dates for the few that we haven't already, and nearly 90% of care home residents have been vaccinated. So care home residents are often, or that they're amongst the most vulnerable to COVID. We've got outreach teams who will go out and vaccinate where we don't have kind of PCNs doing housebound visits. So we've got, as I said, it's like a real kind of system approach, and lots of people working together really closely, which has been a really good experience over the last three years actually, but kind of continues and feels in a way that those relationships are getting stronger. Just with regards to outreach vaccinations, again, it's on one of the slides, but we've been onto ships, we've been to churches and mosques, we've been to warehouses. I think there was a visit to a chicken factory kind of last week or the week before. One of the other things that we're really trying to do is to what we do, we call it MEC, making every contact count. So as I said, we've already done kind of 250,000 flu vaccines, 200,000 COVID vaccines this autumn, only started in September. So just think of all of those patient contacts that we have, and we're starting to use those contacts for other things as well. So using the opportunity to check people's blood pressure. So sometimes we pick up people whose blood pressure is high and it hasn't been documented before. So we're using the vaccine program to identify other problems and get people started on treatment as well. We do have a seasonal vaccination support team in the ICB, and they're a really useful resource. Basically, they just help coordinate everything behind the scenes, and sometimes we have patients that don't quite know how to get hold of their vaccines, so we give out their details, and they'll do all sorts of things to facilitate patients getting their vaccines, and to help all the different centres if they have any kind of operational problems or things that need sorting out. They're a really good source of support behind the scenes. Do lots of communications, lots of social media. You may well have heard me on the radio, on Heart Radio, doing kind of radio adverts. It's really important that we get the message out to people who are eligible and vaccinate as many as we can to keep them and their loved ones safe. Just the last thing I was going to say, kind of next steps. I suppose this is thinking a little bit wider than just COVID and flu, but there's due to be launched a national kind of vaccination and immunisation strategy that I've kind of been involved a little bit in helping to develop. And really what it's going to do is to kind of I think it's going to pull the responsibility for kind of all vaccines down to ICB level. So we're really waiting for that document to be published. I had an email this week to say it should be just within the next few weeks. And then we're going to need to work out as an ICB with all of our colleagues, including the local authorities, public health and the local authorities, our hospitals, primary care, voluntary sector, what we do with that strategy and how we ensure that over the next few years we give all of the vaccines that are needed. So from childhood vaccines through to kind of flu and COVID, and all the schools immunisations as well. So there's an awful lot in there that we're ultimately going to have responsibility for. I think that at the moment kind of sits with NHS England regionally. Actually, one really good piece of news that I had yesterday, particularly around the health inequalities work, we really want to do more about health inequalities and find out how to increase uptake in kind of the hard to reach groups. And actually in Devon, we've managed to find a pot of money of, I think it's about £600,000. So it's a fair bit of money that we're going to be inviting kind of primary care networks to bid for and try innovative ways of expanding vaccine uptake. And that, again, not just for COVID and flu, but it could be for shingles, for MMR, it could be for vaccinations in people with serious mental illness. So we just got the go ahead for that yesterday, and we'll be sending information out in the next day or two. So that's all I was planning on saying. I hope that's given you kind of an overview. I'm happy to take any questions. I'll do my best to answer them. Any that I don't have the answer to, I'm happy to go away and come back to you with.
Thank you, Alex. I've got a question, and thank you for the report and the presentation. I'm looking at your outreach clinics, and you've got your list there. You've got your list of refugees. You've got your list there of homelessness and all of that. Can I just ask, do we ever do an outreach clinic for our sex workers that are walking the streets?
Do you know what? I can't answer that, but I suspect not. Otherwise, I'd probably have heard about it. But I can certainly feed that back.
Thank you so much, because I'm assuming that we probably don't, but there would be a lot of people like sex workers on the street. And the reason why I'm saying that, Alex, is because I have had a conversation with somebody that works with our sex workers, and they have said to me that they're kind of like forgotten. So it would be really, really helpful and good if we could actually start to include our sex workers in things that we do.
Yeah, absolutely. I'll take away to find out. A bit like you, I suspect we don't already, but I can take that to the health inequality cell and then come back to you.
Lovely, thank you. Anybody else got any questions for Alex? John?
Yeah. Thank you, Alex, for the presentation. Can I ask, as it's up to 50% now from 40% in the document for the eligible cohort to be vaccinated, does that leave a lot of spare? And if so, what's the next step for the next eligible group?
Yeah, so to be honest, it's not. When we first started vaccinating against COVID, there were different criteria. So from memory, we started with the over 80s and over 70s and over 60s, and then there were various health conditions. Now we're not vaccinating in that order, so it's kind of anyone that's eligible can come forward and get vaccinated, and not in any particular order. Now, as I said, we're at around 50%. I believe in the autumn programme last year, we made it to about 72% of eligible people being vaccinated, which again was one of the best in the country. We're never going to vaccinate everyone, and if I'm honest, I suspect nationally the expectation is it'll be very difficult to get 72% like we did like we did last year. But actually, when we track, we're tracking kind of where we are this year compared to last year, and I suspect we'll get kind of close to the 70% mark, kind of by the end of the programme. With regards to the vaccine, I understand that there is plenty in Devon, but it basically gets sent to us as we use it. And I think, but there was going to be one of the other vaccines that was going to become available, but I think because nationally, I don't know for sure, but I think nationally, because uptake is a bit lower this year than last year, there is more available in the country, so that I think they decided not to send that to us. But I suppose that the kind of succinct answer to your question is I don't think we'll get 72%. We'll get there or thereabouts. We're on track compared to last year, and we've got plenty of vaccine in Devon to vaccinate those that are eligible.
Okay, Thank you. And you alluded to it then. Is there any evidence that there's a lower, or the reason for a lower take up from some people? I anecdotally hear about people, oh, it hurt last time, I had pains, I don't want it again. So is there evidence there's a lower take up? And if that's the case, what do you perceive as the risk in that situation?
Yeah, I think to be honest, there are always people. I see people in my surgery actually who say, "Oh, it hurt last time," or I had a reaction to it, so I don't want it this time. But I think probably also it is if we turn the clock back 3 years when we first started the vaccination program, actually it was the only way any of us could live a normal life by being vaccinated, and COVID then was a lot more dangerous on a population basis than it is now. Generally, COVID is a less serious illness than it was 3 years ago, and I suspect some people just get a bit of vaccine fatigue and just think, actually, I don't want it. COVID isn't that serious. So I think that's probably the main reason why numbers drop off. As to what's the risk, I mean, for an individual, for any individual, the risk from COVID is pretty low, but there are always going to be people who do get kind of a severe illness from it. And as with any immunization, the lower the uptake, the more it will be in our community, and the more people that will get unwell and sometimes be admitted to hospital or even worse. So so I think it's probably vaccine fatigue is kind of the main reason for the drop off, and yeah, it does slightly increase it will increase the risk for some individuals, but still for any individual, the risk of serious illness from COVID is pretty low.
Okay, thank you very much.
Thank you, Chair. I've got a couple of questions. One was, you said about the uptake. In the past, we've had concerns about health and social care and the uptake from there. Are we finding that there's a pretty reasonable rate of uptake from our health and social care, obviously because they are with our most vulnerable? You mentioned care homes, but in terms of hospitals and care homes and domiciliary care.
Yeah, to be honest, that's an area that is of concern to us, because to be honest, it's difficult to get kind of accurate figures as to how many health and social care workers have been vaccinated, because of the way it's recorded and the number of places that people can go to get it. But we have anecdotally kind of picked up that there is a lower uptake of lower uptake of COVID vaccinations amongst our health and social care workers, which is a worry, because as you say, they work with some of our most vulnerable kind of residents in the county. We're doing our best to work with the local authorities who have most contact with the care homes to encourage care homes and health and social care staff to have their vaccinations. One thing I should say. So I suppose I'm thinking more of kind of health and social care staff in the community. I think in our hospitals we've got a much better uptake. I think probably because they're more used to having regular vaccinations because of flu and where they work.
A quick supplementary, sort of coming back on what John was asking about, are you going to open up? So is the plan at the moment then that you won't be opening it up to the younger element, i.e. people of a working age, 50, 55, etc.? Because, we're talking about winter preparedness, but also talking about making sure that hopefully people aren't off work for long periods of time, as well as obviously the impact. Or is that just not on the agenda this year?
To be honest, it's outside my control. We basically provide the immunisation programme based on the advice that comes out from JCVI, the Joint Committee on Vaccination and Immunisation. So it's them that look at. They look at all sorts of things. They look at data. They look at the strains that are around at the time. They look at the number of patients that have got it, and they make their recommendations based on the evidence. Obviously, I haven't seen the evidence, but the evidence at the moment is that it wouldn't be appropriate to vaccinate the younger age group. But sometimes things change for all sorts of reasons. So one example actually of change this year was we were all set to start vaccinating on the 1st of October, I believe, or beginning of October. And you may remember there was some worry about a new strain that was in circulation in the UK and 4 or 5 other countries. And on the basis of that evidence, the JCVI recommended that the vaccination programme was brought forward by a couple of weeks. So as a system, we can't go out on a limb and say actually we're going to widen the criteria. We're only allowed to do what the JCVI kind of recommend. And as I said, I haven't heard any noise about expanding it to lower age groups, but it will be based on the scientific data and evidence that's provided to them.
Patrick?
Thank you, Chair. Apologies, Alex, if I've missed it from the paperwork and generally are ignorant on this, but what are the main changes in eligibility criteria for the COVID vaccine this year? And for flu, is that the same criteria as previous years, or have there been changes in the eligibility criteria there also?
So flu is largely the same as it normally is, other than for the last couple of years, actually the age cutoff for flu from memory came down to 50, but actually they got rid of that this year, so it's gone back up to 65. So for flu, essentially, it's anyone over the age of 65 and with various medical conditions, and it aligns very largely with COVID. Actually, again from memory, that's kind of aged over 65 and has it has a list of various medical conditions as well that put people at increased risk who are eligible. So if you're a 54-year-old with diabetes, for the sake of argument, you would be called for a COVID vaccine.
Thank you.
Any more questions? No. Thank you so much, Alex. I really do appreciate you coming to us, and we'll let you get back to your surgery.
Lovely, thank you. It's a pleasure. I always enjoy coming to present to this group. So thank you very much for having me.
Thank you.
Thanks. Bye.
Chair, can I just say, I believe Julie, and I'm trying to think what Julie's surname, Freya, can get us the information about what the criteria are for the injections, so for the flu and for the COVID, so we'll get that off them and circulate to the members. I'm sure you're right, John. If you use your microphone, you might be able to be heard.
And if you've got vulnerable relatives, if you care for a relative, I think that criteria is the same.
Well, I know my daughter's having hers tomorrow, and she works in a GP surgery, so yeah. So am I having mine tomorrow. Yeah. Not that I'm 65.
How did you get yours then?
Got an art problem. Yeah. Before we go on to the next bit of this presentation, can I just say it would have been really, really helpful if we'd had this paper well in advance. Unfortunately, we did defer this meeting for a month because the paper wasn't ready, the report wasn't ready, and then we only actually received it 2 days ago, which really hasn't given members time to really look at this paper. So for future, it would be really helpful. Plus, I've had my lead there having to chase on this, which isn't fair when he's got other things that he needs to be doing. I just need to put that out there because it's not very helpful for us, because we have got members here that actually do work. So they've had to change all of their arrangements to be able to come in today. So it would, like I said, it would be helpful if we could just get them on time in future.
Yeah, my sincere apologies,
Yeah.
Chair and members. Fortunately, the timings in terms of how we navigate stuff through sign
Yeah.
but I appreciate we'll make sure you've got it in plenty of time next time.
Lovely, thank you. So we're going to go on to the next part of this presentation. It's the systems plans for winter. So we got Chris, Sarah, and Rachel. Is that right? Yeah, lovely. Thank you very much. Thank you.
I've got my colleague Mel Wilson who's joined us digitally. She's going to run through the mental health section at the end.
Okay, lovely. Thank you very much.
So thank you. So, as we say, so we've got a number of us today who are going to talk through our local approach to winter planning. So there's a process that we go through every year annually through the NHS and with social care and partners across the local system to look at our approach to the forthcoming winter, what we understand in terms of modelling and the demand and pressures we're going to face, and what our response looks like. So what drives a lot of that activity is national guidance that's issued in the year. And this year we had that come through to us with a letter setting out some key areas of focus that we needed to pay our attention to in developing our approach. So fundamental this year, some of the challenges that we've got in urgent and emergency care. So we touched on earlier on in today's session, didn't we, around the position and the difficulty that we have and some of the pressure that we've continued to see, but actually has worsened over the last few weeks. So very much our plans this year are focused around how we can ensure that we've got the right interventions to address those pressures and make sure that we've got the resilience and continue to make the recovery that we need to make, but also place ourselves in the right place to be able to respond to the additional pressures that we know are going to come through. It's very much a system response as well, so there are different components to this. So I'll kind of give an overview in terms of the approach that we've taken this year, some of our learning from previous years and some of the interventions and schemes that we've put in place. Sarah will describe the approach that we take between partners as to how we respond and step in where we've got an escalated state, and then Rachel's going to describe the specific response from a University Hospitals Plymouth perspective as well, and some of their planning that's gone into that. So first of all, in terms of the evaluation that we did of last year and some of our learning on the first couple of slides. So we had a really successful winter last year in terms of a number of schemes that we put in place. We were able to respond to the pressures as they arose, and it was really challenging in terms of the position that we faced, and that was a challenge across the country nationally, but also here. What we did through each of those schemes that we put in place last year, we undertook quite a detailed analysis of actually what was the impact of those, what was the learning, what could we have done differently, and that's where we drew from in terms of developing our understanding for our learning for last year. So breaking that down between discharge and flow, so how we're supporting that flow through the hospital by getting people out in a timely way. We have a really good local escalation process that brings together all partners who are empowered to undertake tactical actions to respond where necessary in order to support the system. So that's something that we can continue that you'll see. We've had a series of schemes that we'd set up and learned through COVID and beyond in terms of things like care hotels where we mobilised those previously, but also responding and bringing in additional capacity in a way that doesn't destabilise the local social care market. So working in partnership with them, but also bringing in extra capacity that enables us to step up extra support when we need to. The bridging service that's referenced there, so that was a real success in terms of bringing on additional bridging capacity to support people coming out of the reopenment service we described earlier whilst they were waiting a dom care package. And you can see in the graphs there, actually when that service came online, it had a real positive impact in terms of waits and then the number of slots that could be offered to. And that kind of brought forward the success that was described earlier and demonstrated in terms of dom care waiting times. It helped us kind of get a start to that during winter, which was really positive. Many of the schemes that were successful in terms of some of the one-to-one support offers that we've had in place, our Admiral Nurse who's supporting dementia discharges, those are things that we've turned into our business as usual processes as well, so they've continued throughout the year, as has our additional VCSE, so voluntary community sector works. We've got some really strong partnerships with local partners who we work with and have continued to make sure that those are part of our discharge pathways. Made events, so real focus around actually how we work together as partners in order to review the discharge processes that we have and make sure that we've got those embedded and being used. And actually we've run a number of those now for Plymouth, but also with Devon and Cornwall partners as well, and that's enabled us to build some really positive joint working arrangements with Cornwall colleagues particularly. And you know, as we were describing earlier around the no criteria to reside position, actually we did see some really significant improvements in that from mid-January onwards, so in the depths of last winter. And certainly, you know, we had sustained that for quite some time, although recognise the pressure that's now built up and our need to bring back some control and focus to make sure we've got the resilience around that. And obviously, from a part of our system response, emission avoidance is stopping people needing to go to hospital in the first place. Supporting them in communities away from hospital is always a key component of our plans. And last year there was a number of things that we set up. So our acute respiratory infection hubs, having a response for people with respiratory infections that gave some additional resource to the emergency department, but also patient communications about where else they could receive support. The Safe Bus, another really good scheme that we extended through last winter, providing support in the Plymouth nighttime economy, and also some of the work we've put and wraparound support we've put in place around care homes. We've also had quite a good flexible approach to the emergency community response teams, so those teams within Levwell who respond to people during periods of escalated need, being able to shift and focus that to support both discharge but also bring additional resource into emission avoidance where that's helpful in order to bring depressurise the system. The work with primary care in terms of the comprehensive geriatric assessments and the model that we've got there that's been pioneered in Plymouth and it's been really successful, and we've rolled that out further. So that's been really positive. And also support from a mental health perspective through the crisis cafes and being able to respond and reduce emissions. And again through the Liverpool First Response Service as well, and having alternative routes for people to access that support in order not to bring them into the hospital. In terms of our learning of what could have gone better, so there's always more we can do and always learning that we can take from the things that we've done previously. So whilst there was real positive moves in bringing external agency staff in to help where we were challenged from a workforce perspective, that does bring challenges. It's expensive to do so and obviously not optimal for where we would want to be, so that's definitely learning that we've taken. And similarly, last year there was a series of short notice funding pots that were released by central government for us to support our urgent and emergency care and winter planning, but there was really tight constraints on what that could and couldn't be used for. So that did limit some of the things that we were able to do, some of our options for deployment. We did do that really well and it worked flexibly for us, but we have fed that back to the national teams around actually giving us more flexibility and more warning of the money is more helpful in terms of how we can spend that in a more tactical way. We've also identified some difficulties that we had around our need to have more strategic long-term plans in some of these areas to make sure that when we were undertaking tactical action it didn't destabilise some of the systems or impact on partners. So we did describe earlier some of the pressures around long-term care need and our need to make sure that all of the interventions that we're undertaking are supporting as many people to have their discharge options, particularly at home, and re-abling them to make sure that the support that they have reduces their need long-term. So you'll see in terms of the approach that we've taken this year, we've taken the learning from that and set out a really clear strategic approach in terms of our intermediate care plan I'll reference in a minute. There was also a challenge in terms of some of the other responses that we had, so some of our force response services and our focus around frequent users of the hospital. We've got some really good schemes locally, but there's more that we need to do to make sure that those are appropriately supported to receive the referrals and identifying the right individuals to support those services. And again, that's some learning that we've taken through into this year. So this year's approach, again, focusing first on that emission avoidance perspective. So we're reviewing all the schemes that we had. Well, we have reviewed all the schemes that we'd funded through the demand and capacity monies. There was monies that came through nationally, was allocated to Plymouth by the ICB, to look at how we can make sure that those are having maximum impact. We've got set recommendations that we're working through in that, and also looking about how we're supporting mental health as well as part of that. We've got a emission avoidance enhanced service that we've developed with local GP practices that we're looking to implement as well, in order to make sure that they've got the support in order to help individuals through their GP practices rather than through community or acute services. We've, as I've mentioned earlier, the comprehensive geriatric assessments that we have, the ICOPE model and the Ageing Well MDTs. So those Ageing Well MDTs bring together the GPs, community services, in order to look at how best to support individuals with levels of frailty and need. We've rolled those out now across all the primary care networks in Plymouth, so again that's really positive. We've done some targeted work in terms of care home conveyances particularly, so ambulances being called out to care homes to take people into the emergency department. So we've got a regular review now that's looking at those cases, understanding what the learning is, how we could have supported some of those individuals to have remained in the care home where that might have been appropriate and possible, and looking at how we bring in different services in to support that. And that's an ongoing piece of work that we'll continue to take through winter so that we can look at that. And attached to that, we've also got the Medicare service that we commissioned to support care homes. So it's a virtual offer that can bring help to care homes, which again takes away some of that pressure from the system and helps those individuals. We've got a GP streaming service as well, so that's a service of GPs at the Derriford site, but can take some of those individuals who are in the emergency department and support them in different ways. And we continue to work to maximise the use of that and look at how we can get the best utilisation. There's also been funding into the Urgent Treatment Centre at Cumberland to look at how we can make sure that we've got resilience and increase the opening hours, and that's something that's being taken forwards. From a discharge perspective, so I mentioned earlier around our need to make sure that we've got the right strategic long-term plan, so that's been a real focus of ours, and we've developed the demand and capacity modelling that's enabled us to be really clear around what capacity we need moving forwards to support people on discharge, and aligning that to best practice in terms of making sure that we've got the right proportions of people going home and the right models for those individuals who need to go into bedded settings. And it aligns to the work that Emma and the team referenced earlier around the domiciliary care market. So it's kind of all comes together in being able to articulate what that process looks like, what the capacity that we need. Building then on our learning from the bridging service last year, what we're looking at developing is a enhanced service offer that aligns to the existing services that we've got, but that will almost double the amount of capacity that we've got for people being discharged at home. And we're moving at pace with that. We've got some further conversations with market and partners in terms of how we take that forwards, but we're going to have that live and running for this winter. And we're taking a two-phase approach to that. So we'll have an initial phase that enables us to bring that online quickly with agency staff, but moving forwards we're working with our partners to look at how we can have a local offer that's more sustainable and employs people locally. And as I say, in terms of that pathway to component as well, so that's those individuals who are going into a short-term bedded setting as part of their rehab journey, making sure that we've got the right model there to maximise those outcomes for them. So this last slide, this just a series of coloured boxes, isn't it? But it starts to try and describe the different meetings and processes that we have in place as partners across the system to work to bring kind of a daily oversight of the system and the pressures that we've got, take the tactical decisions that we need to in order to respond where we do enter periods of escalation. So you can see on the left-hand side there, there's the internal meetings that take place within Derriford, so University Hospitals Plymouth, around how they're managing their process and flow and responding and undertaking those tactical actions and escalating. We then have in the middle the Plymouth system response, and so we've got a bronze, silver and gold meeting cadence that pick up kind of those operational responses that need to take place in order to de-escalate the system when we're in periods of escalation. The Silver then brings together those local system partners in order to look at how we can collectively work in order to help whichever partner's under pressure. And then the Gold element brings together the executive leads within those partner organisations. We've also got a key component of that, the green box, so the social care pressures perspective. So that's where we bring together health and social care commissioning teams in order to look at actually what are the particular pressures that we've got, what are some of the tactical responses that we can bring in place, what are some of the schemes that we need to deliver now in order to help maximise flow, but do that in a way that respects and responds to the ensuring we're getting the right outcomes for individuals. And then on the right hand side, there's the Devon system process as well. So that kind of mirrors what I described around the Silver and Gold approach, but that's where we feed in and link in and request for support from the broader ICB, but also the other trusts within Devon, SWAST in terms of the ambulance services, and also the other local authorities across the area as well. So that was a bit of an overview. As I say, I'll hand over to Sarah now, give that update in terms of where we work with partners.
Thanks, Chris. Afternoon, everybody. I'm Sarah Pearce. I work in Live Well South West, one of the Assistant Directors for Adult Frailty and Specialist Services. So I'm just going to talk through some of the work we do together as partners to think about how we manage escalation together and how we try and de-escalate our position. So there's a national framework called the OPAL framework. You may well have heard on the news when systems are in OPAL for the highest level of escalation. The OPAL framework has been around for a long time, but this year it was refreshed. So the new OPAL framework is very acute hospital focused, and it's kind of much better than what we had before, in that it gives a real consistent approach. So there's a scoring system, so you're given metrics that each acute hospital score themselves, so you know that if you get a score of 12 to 22, you are OPAL 2, for example. So it takes out the subjectivity across organisations of being able to declare your status. So I think that will be really helpful for the acute hospitals over this winter, and that's now in place. For the community, in the old OPAL framework, we did have some community triggers, and at the moment, the revised framework doesn't include community triggers. So we've taken the decision that we want to have that same approach working in partnership, that we want a consistent score. So we've started some work on developing the community triggers based on the old ones, but also adding in things from what we now know that are important to flow. So more focus on admission avoidance, you know, and kind of including those in our scoring. So we've been doing some work locally, and we've involved our partners from the council. We've been working with our partners in the ICB and with UHP and our Cornwall partners, so that we can try and build that together. So we will very soon have our revised community framework, and we understand that next year there'll be some national community guidance, but we don't feel, given our system pressures, that we can wait until then. So we've decided to, you know, deliver our local, and we can feed those into the national guidance, can't we? And kind of give some feedback on how that's worked for us. So that will help us with our OPAL policy. We'll all know the actions that we take at each level. So when it's business as usual, these are the things we do every day that mean that we keep things flowing. And then as system pressure starts to escalate, we have a set of actions at each level that we take and can assure ourselves that we've done everything we can at that level to try and prevent escalation. We'll also then have a surge policy that's going to be across our organisation, so our acute and our community organisations. And those will be extra actions, things that you wouldn't do every day, but that you would do if the system went into internal critical incident or into system OPAL 4. So those are things that you think, okay, today I'm going to take somebody from this piece of work to help in that area, because that will make the difference to be able to de-escalate. But those are the sorts of actions that you wouldn't want to do every day, because it would destabilise the work of the teams. But when we're in those extreme situations, they're the actions we need to take. So we're developing that at the moment. And we've got the task and finish group, as it says at the end. And we met actually just on Tuesday, just to check in on progress, and things are going well. Emma, you were there, weren't you? So we're kind of almost there, really. So pulling that together. So the work we've been doing around admissions avoidance, so Chris has already mentioned some of this. I'm just going to pull out a couple of the pieces of work. So one of the pilots we're about to launch on Monday is our care coordination hub. We're working with our partners in NHS Devon and Livewell are hosting, on behalf of the Western locality, a care coordination centre where our colleagues from SWAST, if they have somebody at home that they think needs an escalation of care, they'll be able to call into the coordination centre. And the difference between what we've got now for admission avoidance and the coordination centre is that we'll have a clinician, so we'll have a doctor in there, and we'll also have a paramedic from SWAST. So we'll have our normal UCR teams with our professionals who would normally say, okay, what can we do together? So we're really hoping to prove that having a wider group in the coordination centre will help to keep more people away from the front door of the hospital and have their care and treatment in the community. So that's one of the things that we're about to pilot. And for care homes, as part of that pilot, there'll be a call before convey. So if a paramedic has been called to a care home, they'll be able to speak to the coordination hub to look at everything else we can possibly do so that care home resident doesn't go to hospital unless, of course, they absolutely need to. And part of that coordination will be that if somebody does need to go to hospital, agreeing their pathway out. So it may be that they need to go in for an enhanced test that we can't do in the community. So the coordination centre team will be able to say, okay, do that test, and then we'll pick that person back up and take them back home and keep them in the community. So that's just one example of the slide. And then no criteria to reside. So no criteria to reside is a national directive, mainly for acute hospitals. So there's literally a list of criteria, and if the answer is no to all of the criteria, the person is deemed as not needing to be in the acute hospital bed. So it includes things like, I wrote myself a little note, whether they are in ITU or high dependency, whether they're on continuous oxygen or non-invasive therapy, whether they're having IV fluid. So there's a whole list of criteria. And if somebody doesn't need those, they don't need to be in that hospital bed. So we know in Plymouth that to meet the gap that we know we will have for winter, we always know we have a surge in winter. We know we need our no criteria to reside to be at 7%. There's a further target for improvement to get down to 5%, but we know that to get through winter, we have to be at 7%. Now, Chris mentioned the MAID event, the multi-agency discharge event, and at the end of that week for Plymouth and Devon, we did manage to achieve the 7%. We've got some work to do with our partners in Cornwall, but it was a really good example of, you know, ways to maintain that 7%. So the group that's been set up have a really kind of, they've got a tough job, haven't they, Rachel, to make sure that we're doing kind of targeted pieces of work to ensure that people who don't need to be in an acute bed can move from that acute bed. And obviously that's a whole partnership, because in community services, we need to be able to receive those people and work with our partners in care homes, in dom care, you know, in our inpatient settings with our discharge to assess teams to make sure that we're all up for the challenge together. I think that's me. Over to Rachel.
Lovely. Good afternoon, everybody. My name is Rachel O'Connor. I'm the Director for Integration, Strategy and Partnerships at University Hospitals Plymouth, and also have the lead role as Winter Director over the next few months in the joint work that we're doing together. So over the next 4 slides, I just wanted to describe to you the modelling work that we've done. This is something we do every year, learning from the Southern Hemisphere and our current start point of the capacity that we need to meet the needs of the population through the seasonal period of winter, reflecting on the year so far. Some of the actions that we are taking as a acute provider, but also then as in partnerships, and the impact of the work that Chris and Sarah has described in how we mitigate some of the increased seasonal demand that we see. And describe how we continue our objective to ensure that we can ensure that we have good access to urgent emergency care and maintain the support for people who are coming in for a planned procedure as part of our elective and planned pathways, and then a little bit about our comms plan. These 4 slides are drafted as me presenting them today because they go formally to our trust board next week, but we thought while we were here today it's really important to share those with you and as part of the scrutiny conversation today. So a few things to just take you through in terms of the output of that modelling work. So very much our approach is in partnership. That's really important to support the needs of our population over this period. But what we've had to do in looking at our winter plan is just take stock of where we currently are in terms of the demand that we see. So going into the start of the year, we expected to see a 2% increase in demand, people who were presenting for emergency care at the hospital. Unfortunately, what we've seen over the last few months is that has increased up to 13% in terms of that demand. And then equally, as we want to maintain flow, and we know that's important predominantly for our patients to ensure that they go to the right place at the right time and we ensure they are in the right setting. We plan for, as Sarah said, a no criteria to reside of around 7%, but at the moment we are broadly holding across the hospital of 14%, which is around about 100 to 120 beds at any one time. Those need to be factored into the plan before we start because that is what we are facing and are important in terms of the overall balance of that need and the capacity that we have as a hospital. But all of those things are things that UHP have a role to play and our partners, and I want to emphasise that. We always look as part of our modelling to learn from what's happened in the Southern Hemisphere. The news from that is that we expect this year the peak in that seasonal illness to come slightly earlier than we've seen. That's around week 26. We expect the levels to be consistent with pre-COVID. Again, that's another good sign because that's lower than what we've seen before. And the peak rather, isn't so severe that we've seen. So those are important learnings in terms of our planning. And absolutely, it is crucial that one of our priority is the health and wellbeing of our staff, and we extend that to our wider partner staff. So our vaccination campaign, and we are setting a priority of a 75% vaccination level. And as Dr. Deegan said, we've made good progress with that. We get the national reporting's a bit of a lag, so I can't give the readout for that. Taking all that into account and that start point, it would suggest as a worst case scenario, we would be facing at the peak that week 26, a bed deficit of 150 beds with the weight of what we are holding. And to be really honest about it, we are not going to be able to build or create 150 beds in that, and our desire is to support people at home as quickly as possible. We've been working therefore to look at what those priority mitigations are. Some of those are already part of us trying to manage the situation as it stands. So because of some of the capital estate moves we've had, the Royal Eye Infirmary that opened a week or so ago, that's freed up capacity within the site. That will give us 35 beds, 12 at the end of October and then the remainder at the end of January. We're increasing and week on week increasing the capacity for care at home, which is virtually and digitally enabled. Nationally, that's called virtual wards, but enrolling more and more patients across pathways and getting some excess feedback. But that is a really positive way to support people back into their setting, whether that's care homes or their own bed. The bit that UHP has a continual drive to do, that's improving our length of stay. Part of the way that we are managing, and I know it is extremely pressured for our emergency department and the number of ambulances we are holding, but some of the way we've offset some of that demand that we're seeing is a half a day length of stay improvement with some of the process that we do, and we aim to go a step further and increase that by another half a day. We have our role to play to support the extra capacity that's coming online with domiciliary care and the dementia beds in launching a real campaign across our trust around describe, don't prescribe care. So we really think about the holistic needs of people and why not home, and that continues to be support, obviously suitable where that is for people's needs. And also at the front door, the ongoing improvement work that we're making around the timeliness of response for support into the department and how we can decongest the emergency department by supporting people to the right specialties. So our same day emergency care, our frailty unit, and that continues to embed across the hospital. When we take those things to account, the draft scenario would suggest we would still have at the peak a 30-bed deficit. But what I would say, what we haven't factored into that is the waterfall that Chris was describing about the admission avoidance to go in, and we think we need stretch on our virtual ward. So we aim absolutely to close that, and that's important because some of that capacity I've mentioned is new and is permanent. That means as we exit then into 23-24, there is a better demand and capacity demand that we need to aim for. So that was an overall summary of these. This is a description of the kind of 4 key areas that I've described, the bit we work in partnership and the bit that we work together, and hopefully you saw that in the description that I gave. The next slide talks through quite specifically how we start that waterfall. These are the waterfalls that we describe with that overall bed deficit, the mitigations that I talked about, the specific action on top of that we're taking on our planned care pathways in how we're protecting our specialist beds, how we are looking at test of change around how we can change some of our bed capacity to same day emergency care so we can get throughput and quicker assessment for individuals, and how we particularly look to reduce our medical outliers because that's important for the quality of care for individuals, how our agencies can work with those, and how we get then a better flow through the hospitals. And as I've said, the working area that we still have, which I think from the modelling as it stands, it looks like with those admission avoidance we could get to a 18 beds at the peak, which is a much more manageable in terms of what we're seeing than the 30 beds. And then finally, I did want to talk a little bit about communicating. I think our agencies already with the local authority work really well around our communications. It's so vital to get key messages out to the public, both in terms of things they can do to support themselves, how we can access care, some of these new things like care at home, virtual wards, what that is in a way that's meaningful, that talks to our public, and specific campaigns at particular points of the year through the period to support. And I'm really pleased that we do that in partnership in the work that we set out, and that's a short plan of the timescales, how we will do that, and the impact that we expect that to have. So I'm very conscious of time, so I appreciate that's a whistle-stop tour, but in the pack there is more detail around the types of capacity that are feeded into the bed model and some of the variation of what impact that makes. Thank you, Chair.
Thank you all. Has anybody got any questions? Steve?
Just a quick one. Thank you for a very comprehensive presentation. Is there anything, just a bit out there, anything we can do to sort of help in the community as councillors? Is there anything you can think of quickly? Because I mean, there's loads of words there.
Yeah.
Is there anything punchy? Is there any specific campaign at the moment we can just get out there?
So I think the communication pack that we put in there in terms of the slides, some of the key messages in there, and it is, you know, it's the things that we've been describing for some time, isn't it? But actually, people using things like community pharmacies and some of the other resources that actually, if they are feeling unwell, that they're using those where it's appropriate to do so. So certainly there's that aspect, isn't there? Anything you want to add?
Yeah, the Choose Well campaign, really. You know, so it is exactly that. So the Choose Well campaign. So it's a national campaign. If people Google it, if you Google it, it gives you know, our general public, our population, just ideas of where to go first. You know, and I think it's really hard, isn't it? Because we know that when services are busy, if people go to the emergency department, they may wait, but they will get seen. And it's how we can work with our public to help them to not choose ED first, to, you know, to only go to emergency department when it is life-threatening, really.
And I think the messages around vaccination are really important. We have particular campaigns around where family members are helping to support people home, that can be earlier in the day, because that means we can then move those people that have arrived in the morning seeking care, but also listening to what people are saying about things they're struggling to access. I think that feedback loop, again, is really important. I wonder, as an action with the comms plan, Gary, we maybe have a short, you know, what plan on a page of things of key messages, if that would be helpful into surgeries that you're having as a suggestion.
Yeah, that would be great. If you've got any social media things you can send to us, we love that. Just quick things we can fire out. Be great.
Fantastic.
Before we go any further, I've got Mel on screen. Sorry, Mel. Would you like to say anything? Sorry.
No worries at all, thank you. I just wanted to echo that from a mental health perspective, really, because we've got a huge offer in the community now of mental health services, thinking particularly of our first response service, which, you know, a few years ago we didn't have that type of access for people. It's instant access straight through to somebody who can support and understand. It's a 24/7 offer. Similarly, at the kind of lower end of things, we've got our primary care mental health team model, which offers, you know, sort of lower level mental health support, but also there's sort of 15 different groups that people can access. So there is a huge suite of offers there for people, again, sort of as particularly the first response offer as an alternative to actually attending ED. So I think, you know, we would definitely want to join that comms really and make sure people are aware of what they can access.
Thanks, Mel. Mary?
Thank you.
Chair, can I suggest that we look at this and see how we can distill it down a little bit easier? The communications plan on the page is quite complex to look at, so let's see what we can distill it down to, and let's see what we can be getting out to councillors and also on the council's website as well. I think that needs to be the other essential thing, because sometimes council's website isn't always the easiest to go through.
Just a quick one. Mine's really about COVID, because I spent a lot of time at the hospital at the beginning of the year, and I saw many cases of COVID in the wards, which held up people that actually really could have gone home, but they didn't, and so it was obviously bed blocking, which caused major problems. And this, my fear is obviously with the winter, because it is going to be winter and we're going to probably have a lot more of it. You couldn't cope at the beginning of the year, if I'm being totally honest. I'm not going to go into detail here of what I've seen and what was happening, but so it worries me that through the winter there is going to be major problems up at Derriford, and I just don't know how you're going to address that.
So part of the modelling, obviously we learn from what happens as and when that people come, and the balance here is about what we can do to offset that misbalance that we have. In terms of COVID specifically, what we found over the last few months, because we've always had peaks of COVID through the year, is that actually people aren't necessarily in hospital because of COVID. They have COVID as well as something else that is the main reason for those individuals being there. So that's the balance of the two things that we work with. Part of the surge plan, I think that's something that's different this year, Chair. So what we didn't have in the cold light of day, when we're not having to turn something on or off in terms of extra capacity, that wasn't written down. It wasn't part of a surge plan, an action plan. That means we know we've got that peak coming, and we can't have the capacity, we know, in 2 days' time to meet that. So that's the action those action cards will do. So actually, we might need to ask this particular team to focus more on discharge, or we might have to say to our health visitors, actually, can you look at this caseload? And that we plan that now, so that we've agreed those set of measures. And that wasn't something that was there last year. And I think that is really important and a key part of that escalation surge this year.
Yeah, I mean, these were people that had not gone into hospital of COVID, but they'd caught COVID while they were in there. But what I actually saw was wards themselves not doing anything to help. Does that make sense? So what can I say? So there was no signs up to say that there had been COVID in that ward. There was cases of COVID in that ward. There was people wandering around that had COVID, and I know you can't. It was quite interesting actually, because I did ask about doors, and there was no doors put in place. So there, for doors, it's deprivation of rights for patients, and so there was no doors put in place. So there was no way that you could have said to patients that they had to stay there, because you have to put a date on it. You know that, and I know that. And but they were still insisting that these patients weren't allowed out of these cubicles. So it was causing major distress to patients that were in there, and it just worries me that things won't be put in place to avoid this.
So in the part of the action plan, it probably didn't go to that detail, is actually how we look to, it's use the infection control guidance that really determines the flexibility that we have and those guidelines that we follow. But specifically this year, both for respiratory infection and for COVID, we will look about how we cohort actually and how we manage that. So sorry, Chair, if I didn't articulate that. So those are some of the measures that come in terms of that infection control. I know there are some hospitals around the country that it was in the news around bringing back masks. I think we will take those measures as we see those surge again as some of those preventative measures. But I'm sorry if that was the experience, and certainly we'll take that back in terms of our retest of our infection control procedures.
Thank you. Mine's very minor compared to that. Obviously, we've spoken about sort of getting everybody on board. Going right back down into the chain, if we're thinking about minor things, actually people start blocking the urgent care service rather than going to their GPs to have things done. For example, redressing of wounds from falls, that type of thing, because everything sort of leads on, doesn't it? If something doesn't get redressed when it's meant to, then we end up with infection, blah, blah, and it goes on and on. So have we got the GPs on board with that to make sure that actually, instead of compounding an issue by having people do something locally, but being sent back to urgent care, treatment urgent unit, to actually have things, that should be done more locally? Are they on board, or is that going to be part of your request to them?
I think it's a really good question, and so we've done an awful lot of work over the last year and working in partnership with GPs within the city, and there's been a big improvement programme that we've looked at actually how is some of that interface between the hospital trust and doctors and some of the expectation and GPs in order to look at how we can make sure we've got the right offer. So certainly there's been that component over the last year. I think in terms of, as you say, around that blocking up, in the process, that's obviously a key component of it, isn't it? And it comes back to that, people using services like 111 as well right at the outset, in terms of actually where that's an appropriate route and can help direct them to where they need to be in the system. But it's something that we'll continue to work with partners around, and I did describe one of the interventions we've done is looking at that admission avoidance support offer with local primary care practices and that enhanced service, and actually how that can help us make sure that individuals who've got those needs and whose needs escalate during the winter period can be supported within primary care, and try and support fewer people where we can keep them out of hospital, keep them out of hospital.
Paul?
Thank you, Chair. All the plans are fantastic and I've great faith in them, but what happens if, despite your best efforts and planning, for reasons beyond our control, there's too many ill people in the city and there's not enough beds? Is there a contingency plan or external help available?
So that's where our surge planning and the community plans that we've described. So that's where, as partners, we've got those measures that we'll kind of deploy in order to release the capacity and look at where we need to refocus and reprioritise support in order to see ourselves through there. And also that's where the opportunity that we have as well from a Devon system perspective. So where we can work with our partners across wider Devon, the other hospital trusts, whilst the other services that we have access to, in order to make sure there's a Devon system we can manage those peaks where we see them.
So that means there is sort of capacity for external help. You could send people elsewhere and stuff like that.
It's about relative priority and risk, isn't it? And how we as a bigger system best respond to that. I mean, it could be any number of things, or it could be seeking additional resource or funding where that's available. That's quite challenging. But what else can we bring in to support in order to respond in particular areas that are having particular pressures at any one time?
So I just want to add to that, because I think one of your charts, Chris, you saw the silver, the bronze, the silver, the gold, and you saw it for Plymouth and you saw it for Devon. So because of the such a wide range of things that can happen and that do happen in our system to support people. That's the structure that then looks at, oh, it's this thing that's happening, therefore this is how we're going to escalate and this is the response. It's hard for people to just say, we'll do this, because it will depend on the presentation or the nature of the issue. So you could, let's use our memories as an example, at one point where COVID had hit workforce really hard, you get a workforce generated problem, so your response has to be in line with that issue. Sometimes you might get a prevalence of a particular condition. And so the structure is there, the plans are there based on the knowledge and experience that people have got. But until the moment that arrives, that's why you have that escalation and go process, which goes, oh, it's like this, the response needs to be that. And that can mean people go to different places. It can mean there's a pressure in one place, not another, and you can try and equalize. But until you live that moment, which is why the escalation, and I know people, if you're around us long enough, you hear about drum beats and all of those. It's that keeps watching, sees the issue and puts in place the mechanism. Just trying to
Just to add to that, I'd say it works all the way. So I was previously in Cornwall, and some of the things that might happen, there might be a care home with staffing, with sickness that goes down. Actually, how do the wider partners reach to think about how they might use their bank to support that? So that, because often the escalation that we see starts in community, and you can so actually our wraparound is both ways in terms of adult social care, our community, our care homes, and that's the plan that as a collective team is being worked through on any angle. So I would just say it's not absolutely all about the acute. It's very much any one of us that might be in that point of escalation, Gary.
John?
Thank you, Chair. Dare I go back to this bed problem again? It's in the winter particularly, beds are an issue, things get cancelled, routine operations. It seems as if the problem is still Cornwall. I'm asking you, is the problem still Cornwall? They have more patients than they should have compared with Devon and Plymouth staying in hospital when they don't need to be there. It's not good for the patients, and some of them, from my recollection, were having quite long extended stays when they didn't need to be there. So if there wasn't a Cornwall problem, would you have this bed deficit that you're predicting? And what could be done about it?
Yeah, so that's why the plan has factored in our current overall no criteria to reside position. So broadly, Plymouth has been sitting at around about 13% compared to 7%. Cornwall at points are flipping up to close to 20% compared to 7%. What we have seen with the targeted escalation and the MAID events that Chris has been describing, the length of delay and the number of people that are over the point of 21 days has reduced, but we still have more than the proportionment, shall we say, cancer that we would say. So there is specific actions in the same way that Chris is describing investment in P1. So I spoke to Cornwall this morning. There is additional domiciliary care provision happening in the north and the east. That's important for the flow that we have there. And I've actioned, as well as daily escalations, we're looking at a similar MAID event next week for some of our patients, particularly with dementia and care home waiters, which is the next area that we are struggling with in terms of delays and the action that Cornwall take. But even with Cornwall aside, overall, because we're at 14% compared to 7%, that bed deficit would still be where it is.
It does seem like the Cornwall position's got worse from what it might have been 6 months ago. So how many beds over and above the 7% that Cornwall, that's the norm, how many beds more are they blocking at this moment? Have you any idea?
So I'd have to do the proportionment to do that. But yes, we saw some improvement over the summer. So there was some injection in terms of additional capacity that went in. That came down to close to 10% over the early start. Then some of the seasonal demand that we see with some of the hospitality saw that increase over the summer, and usually that recovers by now, and it hasn't. So we are in regular conversation about the escalated actions that we need Cornwall to take, and that's a key part of their assumptions as well that aren't yet factored into this plan and that 30 deficit that I currently shared, but we need to factor that in the next final draft.
I've got John, and then I've got Will, and then we're gonna close this bit of the meeting. Okay. So, John.
Thank you, Chair. can I just, applaud you guys for a very well evidence-based, considered plan and so on. And obviously it is a plan, knowing what's to come, we could have Mystic Meg here and all that might help and so on. But I've got two questions. Will there be an inevitable elongation of the waiting lists over the winter period? I suspect what the answer will be. And also, will success be we fulfilled the plan or we almost managed to cope?
So in terms of the waiting list, the way that we do our trajectory in terms of the starting wait list at the beginning of the year and the end of the year has that forecast in terms of the seasonal that we have. So the part of what I presented in protecting that elective capacity is to ensure that we can keep in line with that profile that we said. There are a lot of unknowns, industrial action in terms of the effect that we have, staff sickness. We're trying to mitigate that obviously with our staff vaccination, but we are planning going into this, and our aspiration is that we are keeping to our seasonal plan for the year in terms of where we are in terms of waiting lists and continuing our waiting list initiatives where we can, because we know helping people keep well for longer is really important. And this is a plan, but it's based on our learning from previous years, as Chris has described, and actually the calibration that we have on some of those areas. Now, what happens is this launches from our trust board, and some of the work has already started, of course, because it's about the seasonal pressure that we have, and we have some key metrics that help us give a temperature check of where we are in terms of this, because really we've got the month of November and early December to make sure that we keep abreast with that. And I think that's our opportunity for the surge plan that we describe as a locality. The degree to where we take the call in those gold meets to say we can see this coming 2-3. It's the proactive bit, Councillor. I think that helps drive. So we know in a week we might hit a challenge with a longer delay for domiciliary care. What do we need to do is that preventative action a week ahead of time, not on a 2 o'clock meeting and try and action it by 4 o'clock, because it has to be their proactive nature, and that we've done the risk assessment that those things will have an impact. Again, back to your evidence base, but be taken in a sensible mobilisational point.
Okay. And the success criteria, just about being able to cope? Now, how big will a few be at the end of the winter period?
So our success remains on us delivering on our UEC plan in terms of our 4-hour performance, our ambulance hold and our elective wait, and our infection control and our vaccination, and those continue to be our success factors through the period. This plan is about how we offset those additional pressures to continue with that. It's one plan with this seasonal element that we need to gear.
I'm sure it's all our collective will for this to work as well, for the sake of not just the patients who need care, but also for the staff and the administrators in the hospital, so that it can actually get through. So good luck. Okay.
Well,
on some of the previous scrutiny committees I've attended, their focus is perhaps, when you talk about last winter, they looked at to stop people going into hospital as being perhaps a focus, an area of focus. This year it seemed that was a constraint, if you like. It was stopping people coming in. That was seen as perhaps a solution or a strategy. This time you look like you're planning for the discharge, so it's the people leaving the hospital as a strategy. Is that a fair change? Does that reflect, have you got as far as you can with moving people away from the hospital, and you've now got to look on the next, you've loosened that constraint, but you've now got to the next bottleneck?
We're doing both. I think it's fair to say. So the admission avoidance work that I mentioned around the care coordination hub, that's in the community. So that's people who are in the community setting, whether it be at home or in a care home. If they are at risk of going into hospital or escalating care, they would go through this coordination hub to look at how we can manage them in the community, if it is of course the right thing to do. The other thing that's happened since we came to talk to you last winter is there's been a real standardisation across what's called our urgent crisis response services. So we have national standards now,
that if somebody is at risk of a crisis in their own home with frailty or, you know, kind of an infection, that we get to them and assess them within 2 hours if they are at risk of going into hospital. And in the Plymouth patch, we consistently overachieve on that target. So we get to see people. So in our Plymouth team, in the last few weeks, we've had, the last 2 weeks, we've had 43 and 53 referrals into that service to help keep people out of hospital. In addition to that, we have the virtual ward that Rachel mentioned. So our community urgent care nursing service form part of that virtual ward. So the hospital give the consultant oversight and help with interpretation of tests and things like that. And then our nurses in the community actually kind of give people their fluids, their injections, so medicines through injections, antibiotics and things in the community setting. So they're having kind of hospital level care, but in their own homes. So all of those things are growing over winter. So I would say we're doing as much to keep people away from the front door as we are to focus on exiting people.
I'd like to thank you all very, very much. It's been really, really interesting today. So thank you for all your hard work. And I mean, I know it's not easy. So, but good luck with it all. It's not going to be easy. So, but thank you. Item 10, tracking decisions. Elliot?
Thank you, Chair. I'll keep this one brief. I've put the tracking decisions into a new log for members. Hopefully the colours are more visible. With the exception of 3, they're all making good progress or complete. The 3 that are awaiting action have now been raised to senior management for chase up following a meeting with myself, Gary and Chair. We've had 8 added today. And if members want to flick through that report, or hopefully have any questions I can take. Thank you.
Everybody happy? I think everybody wants to go home. Yeah. Yeah. No, you have to do, if you do what you need to do.
Obviously, you said they've been escalated because I've got comments regarding some of the ones that are obviously awaiting action, etc. So they've been escalated, and are we awaiting a response soon? I mean, I'm just going to pull out the first one about youth parliament, you know, and you know, evidence that was submitted by them. So, you know, when should we expect that senior management will actually be doing something to chivvy this along and get some results?
So I sent that chase up, including with senior management, approximately 4 days ago. I think it's listed in your report. If I don't hear by the end of the week, I will be chasing and raising further.
That's what you seem to do, Elliot, is chase. Which isn't fair. Okay. So we're all happy with that. So item 11, work programme. Does anybody want anything put on the work programme? And I think I had this conversation with you, Elliot, about pharmacies and the lack of people being able to get their scripts and stuff, because we've also got a problem now where we've got pharmacies closing down within the city, so it's even going to get worse. So I think that really needs to go on our work programme. Does everybody agree with that? Yeah. Anybody else got anything that? Yeah.
Can I ask, even though I'm not normally a member of this committee, will what's been reported today and the data be tracked at each meeting? The performance of what's been shared with us today in terms of the plan, the winter plan?
Yeah, through you, Chair. So anything that's gone down is as an action, and I've got 8 of them from today. Will come back on this action log. In terms of reviewing the actual progress of the winter plan and its performance, that would be something for the committee to add to its work programme to bring back in, say, 3 months' time, 2 months' time.
Thank you.
anybody got anything specific that they would like to put on the work programme? If not, we'll just leave it to Chair, Vice Chair. I think that's been answered. Okay. All right. Well, oh, thank you. Item 12, there is nothing, nothing. So thank you all very, very much for attending. Oh, sorry.
Sorry, through you, Chair. Just to say that the next meeting of this committee is scheduled for the 14th of November. As this meeting itself was pushed back 4 weeks to allow a report to be seen, that's now only 19 days away. So my recommendation is that we push it back a month to the 13th of December, which is our usual Wednesday, and that will give us a nice 2-month period between the next one.
Steve?
Just sort of talking out loud, when you're thinking about the items, if there's something where we can link in with health and sport in the city, I don't know how we can get into that, but it'd be nice to see how sports provisions help in health in the city. I'd appreciate that. Thank you.
So, thank you all very, very much. I know it's gone on longer than what we thought it was going to be, but actually I think it was really quite informative today. So, thank you all for your questions. It was really good, and I'll see you all again soon. Thank you.